Okay, so in the yesterday session, we have discussed up to the clinical reflexes. Okay, I've told you a trick to remember all these clinical reflexes, which are 1, 2, 3, 4, 5, 6, and 7. Okay, when you go from bottom to above, it in the sequence, right? You have the S1 and S2 for the Achilles reflex, the L2, L3, and L4 for the patellar reflex. For the biceps, you have C5, C6. For the triceps, you have C6, C7, and C8. Okay, for the cremastic reflexes, you have L1 and L2, and it is taken up by the genitofemoral nerve. Then you have the anal wing reflex for the S3, S4, and S5. Okay, mainly S3 and S4, but S5 also does that. Okay, then you have the primitive reflexes. Okay, and you don't need to remember the name of every reflex, just 2 and 3 reflexes are important for you to identify, because whenever you get any frontal lobe damage, okay, then all these reflexes will come back. Okay, will reappear in the adult life, because all of these reflexes, they must be disappear within the first year of the life. For any frontal lobe lesion, okay, you have the inhibition of these reflexes. That means in the adult life you can get these reflexes again, right? The first one is the Moro reflex. Okay, and that happens whenever you just uh, kind of whenever the patient was falling, the baby was falling. Okay, so what they does, they will abduct or sometimes extend their arms. Okay, and this reflex is also known as a startle reflex. And if you guys remember one disorder from the biochemistry, the Tay-Sachs disease, okay, you have an increased startle reflex, okay, in case of the Tay-Sachs disease, right? And that was the disease, right? The Moro reflex was there. Then you have the rooting reflex. Okay, whenever you touch any side of the cheek of the patient, they will turn their mouth. Okay, and that is for the nipple seeking. So this is a rooting reflex. Then you have the sucking reflex. Okay, and because they suck anything, whatever touches the roof of the mouth. So if you touch your finger on the roof of their mouth, they will suck it. So this is a sucking reflex. Then you have the palmar reflex. Okay, and this is also known as the Graf's reflex. Okay, the curling of the fingers if the palm is stroked. Then you have the plantar. This is the most important one, and that you will see clinically also, the Babinski sign. Okay, and this is happens whenever you got a upper motor neuron lesion. Okay, you will have the fanning of the toes and the dorsiflexion of the large toe. Okay, dorsiflexion, or I can say the extension of the large toe, and the fanning of the other toes whenever the plantar side is stimulated. Okay, so this is the Babinski sign that you will see in the upper motor neuron. This is the most important one. You can forget every one of these reflex, but you must remember the plantar reflex. Okay, then you have the Gallant reflex. Okay, and similar to other ones. Okay, just remember the Babinski for it, right? Then you need to remember all the dermatomes, because whenever you got a case of reinfection, or the HSV infection, okay, or not the HSV, but the varicella zoster virus infection, or HSV also. Okay, so you know that in the reactivation of these viruses, you will have a dermatomal involvement, right? So with the help of this dermatomal distribution, you will be able to identify, right, what dermatomes the disease is affecting, or whether it is the reactivation syndrome or not, right? So for example, you already know that the trigeminal nerve supplies your face, the V1 nerve up to the eye zone. Okay, the ophthalmic division of the trigeminal nerve supplying your forehead, eyes, as well as central part of your nose. Okay, the maxillary nerve supplying your cheeks, upper lip. Okay, the mandibular nerve supplying your lower lip and the jaw, and up to the temple part, as you can see. Then you have the C2 dermatome supplying your ears remaining part. Okay, C3 for the neck, C4 for the triceps, for the trapezius part and the shoulder. C5 again the shoulder, and it takes part in your brachial plexus. The brachial plexus start here. Okay, so C5 here, as you can see. Then you have the T1 supplying the mid side of your arm and forearm. Okay, then similarly T2, T3, T4 supplying other areas. Okay, now the C6 supplies a lateral part, as you can see, up to the thumb. Okay, and the C8 supplying the most middle part, that means a little finger. And you guys already know that the ulnar nerve is made up of which roots? Anyone?
Could you please repeat?
ulnar nerve. What roots made the ulnar nerve?
C5 to T1.
C5 to T1 made ulnar nerve.
Or C7, C8
C8,
and T1.
C8 T1.
C8 T1 mainly, right? So as you can see, the C8 supplying this your little finger, and that's why the ulnar nerve also supplies your little finger, right? So you need to remember all these rheumatomal distributions. Okay. Now on the back of your hand, the C7 in the middle. Okay. C6 at the very lateral, just like here. As you can see, C6 always at the lateral, and C8 is at the middle, as you can see, right? So this is a dermatomal distribution of your hand. How you can remember? Remember the last one. Okay, the C6, C7, and C8 supplying your hand, as you can see. Okay, C7 that will be in the middle, C6 in the lateral, and C8 in the medial, very middle, right? Then you have the upper ones and the uh, and the extreme lower. That means the C5 and the T1, right? So they will be supplying your arm and forearm. Okay, C5 on the lateral and the T1 on the middle. Okay, so C6, C7, C8, C5, and T1. That's how we will learn these. Then comes the lower limb, and all of these rheumatomal distribution, they will forming a V, as you can see. Okay, they will be forming a V shape, right? If I annotate it, you can see that all of them are forming this V kind of shape, right? Okay, so yeah. So the upper part, this is for the L1. Okay, then up to the mid of the thigh, you have L2, like here. Okay, then up to the mid of the leg, you have the L3. Okay, up to the lower, up to this toe, the first toe, you have the L4. All of them starting in your hip, right? Then for the lower limb or for the leg, you have the L5 supplying the anterior portion of your leg. Middle portion is by the L4, anterior portion is by the L5, and the lateral portion is by the S1. For the posteriorly, only the S1 and S2 supplies your thigh and your leg. Rest all S3, S4, and S5 they supply your anal region, right? Okay, and then again the S2 and S3 supplying your testis and the penis, right? So this is a dermatomal distribution of your lower limb. They will give you some kind of a rash, okay, which is in a dermatomal distribution, and they will ask you what dermatomes this rash is affecting, right? So you need to identify the dermatomes, or they will give you some kind of a rash and they will ask you if this is a reactivation syndrome or not. So you need to look for the dermatomal distributions. Sometimes more than one dermatome are also involved, right? So make sure you identify that kind of lesions. So C2 supplying the posterior half of the skull, C3 for the turtleneck skirt, okay, shirt, and then you have the diaphragm and the gallbladder, because you guys know what nerves. Okay, it is already written. This phrenic nerve, which is for the C3, C4, and C5, as you can see, the C3, C4, and C5. Okay, so the nerve roots which form the phrenic nerve, they also supplies and that part. And whenever you got the irritation of the phrenic nerve, the pain will always refer to these areas, and that's why the pain of the heart attack sometimes it refer to the shoulder and to the arm and then the jaw, right? Because the phrenic nerves, the roots which are supplying the phrenic nerve, they also supply the C3, C4, and C5 their part, right? So whenever you got the irritation of the diaphragm, whenever you got the irritation of the pericardium, okay, the pain always refer to your shoulder and to your arm and then to your neck and jaw, right? Because of these dermatomas distribution. C6 for the thumb, T4 at the nipples, as you can see. Okay, and T4 is the basically the dermatome, or you can say the spine level, where your trachea divides into the two bronchus, right? Two major bronchus, the T4 level. Then you have the T7 where the xiphoid process lie, right? Okay, T10 for the umbilicus. And whenever you have any kind of a pain or any kind of a irritation or any kind of an infection in your midgut, okay, the pain always refer to this T1, right? The appendicitis pain, for example. Okay, then you have the L1 for the inguinal ligament. Okay, L4 for the knees, and like I told you, remember the L4 only. Above that you have thigh, below that you have leg, right? That means the L5 for the leg part, and L2, L3, and other parts for the thigh. You have this pudendal nerve, which is made by the nerve roots S2, S3, and S4, right? That supplies the penis, that supplies your anal region, right? So yeah, that would be all on the rheumatoid. Any doubt? Any doubt?
No, thank you.
No, thank you.
Okay, so we are done with the anatomy, physiology, and the embryology, and now let's discuss some pathology. So first, you have any frontal lobe lesion, and because you guys know that this frontal lobe, it contains what regions?
Broca.
Broca's area, okay, and frontal eye fields,
Motor
prefrontal,
primary
yeah, prefrontal
primary motor
cortex is
cortex.
also there.
Premotor cortex.
Yeah, prefrontal cortex, yes. So, and I told you one thing, remember, that whenever that this prefrontal cortex, it also connects with the limbic system, right, to control your behavior, to control your feelings, right?
Yeah. Yeah.
So whenever you have any frontal lobe damage, okay, you can also have the orbital frontal cortex lesion also, okay, which is a part of a frontal lobe. And whenever you get the orbital frontal cortex lesion, you will have the personality change. The patient will become very rude, very irritable. Okay, why? Because this region has a very strong connection with the limbic system, like I told you, right? And
Yeah.
as I mentioned in the last page, whenever you get any frontal lobe lesion, you will have the reemergence of all the primitive reflexes. And the major one is the Babinski reflex, right? So the patient will get a deficit in the concentration. The patient will get a disorientation. The patient will get an impaired judgment. He will have the reemergence of the primitive reflexes. Personality changes will be there. Rude behavior will be there. Irritability will be there, right? So whenever you encounter such kind of a patient who was very much nice before the incident and now he become very rude, irritable, that means the patient is having a orbital frontal cortex damage. Whenever they have a reemergence of all these reflexes, that means the frontal lobe damage was there. Okay. Then you have the frontal eye fields, and the frontal eye fields are responsible for your gaze movement. Whenever you want to look left or whenever you want to look right, the frontal eye fields are responsible for that. Okay. And if I annotate it, like let's say these are your eyes. Okay. And this is your cortex, let's say. Okay. And this is your right side. This is your left side. Now, okay, so when what happens is whenever your right cortex activated, okay, it will make, just give me a second. Okay, now whenever the right cortex activated, okay, it will make the eye look towards the left side, both the eyes. And whenever the left cortex activated, it will make the eye looks on the right side. So kind of opposite. Okay. Now, whenever you get a left-sided lesion, that means your left cortex get damaged, the right cortex will take over and it will make the eye look towards the left side, right? And that means towards the lesion. Okay. And whenever you got a destruction or any kind of a lesion in your cortex, let's say the left cortex, because you guys know that all the innervation will be on the right side, right? The left cortex will be supplying all the innervations on the right side, all
Yeah.
the sensory innervation, all the muscle innervations, right? So what you can get because of this cortex damage, you will get the loss of senses on the right side. Okay, you will get the paralysis on the right side, and you will get the eye deviation on the left side. That means opposite to the lesion. Sorry, I mean opposite to the side of hemiplegia. Okay, or the loss of senses. That means towards the side of lesion. Are you getting my point?
Yeah.
So just remember the frontal eye fields. Okay. If the right sided get activated, it will make the eye looks on the left side. If the left sided get activated, it will make the eye look on the right side. Okay. So whenever the lesion happen, the eye will deviate towards the side of lesion. And why this happen, we will discuss that in the ophthalmology section later. Okay. Just know this for now. Okay. Then you have the parapontine reticular formation. Okay. And the function of this formation is to activate your sixth nerve. Okay. Now, what happens is whenever, again, let's draw this. You have the cortex. Let's discuss all this pathway. You have the midbrain here, divided into two, and then you have the eyes. Okay. You have the pons just below the midbrain. Now, whenever the cortex get activated, okay, the function of this is the right side and this is the left side. The function of the left cortex is to make the eye looks on the right side, and the function of right cortex is to make the eye look on left side, right? Now, whenever my left cortex get activated, it will send the signal first to the pons. Okay. And then what does this pons this? You have this sixth nerve in the pons, right? The sixth cranial nerve. Okay. Am I audible?
Yeah.
Yes.
Okay, you have the sixth nerve in the pons, okay, and the third nerve in the midbrain. Now, in order to get a coordinated movement, the transmission of impulses must be very fast, and that is done by the MLF, okay, the medial longitudinal fasciculus. Okay, now what happens is the cortex will activate first the parapontine reticular formation. These parapontine reticular formation will activate the medial lemniscus. Okay, sorry, the medial longitudinal fasciculus. This medial longitudinal fasciculus will activate the third cranial nerve. Okay, and that's how you will get the simultaneous activation of sixth nerve and the third nerve. Okay, now the function of sixth nerve is to activate the lateral rectus. Okay, and the function of third nerve is to activate the medial rectus. Okay, so in order for the left brain, okay, to make the eye look on the right side, they need to activate the right lateral rectus, okay, and the left medial rectus, right?
Yes.
Okay, now, so when this cortex activated, it will first activate the pons, okay, the sixth nerve. This nerve will supply to the right side of the eye to this part. Okay, after activating the PPRF will activate the sixth nerve. PPRF will send a signal to the MLF. Okay, the MLF will go contralaterally again, that means ipsilateral to the side, and where it will send a signal to my third nerve nucleus. The third nerve will go to the this side of the eye, and it will make the eye look on the right side. Okay, so the ipsilateral side of cortex, this cortex, it will send the contralateral pons signals, the PPRF. Okay, the contralateral side PPRF will activate the sixth nerve. Okay, so that it will cause the contraction in the lateral rectus of the opposite eye, the right eye. Okay, as well as it will send the signal to the contralateral MLF, so that the ipsilateral to my cortex, that means this part, it will get activate, and it will activate the it will contract the medial rectus of my ipsilateral eye. Okay,
Yeah.
so much contralateral and ipsilateral I know. Just know that the cortex will activate the contralateral pons. The pons will activate the contralateral midbrain, or you can say the ipsilateral midbrain to the cortex, and as a result, you will get the contraction of the lateral rectus of the contralateral eye and the medial rectus of the ipsilateral eye, and that's how you will get the gaze movement. And please note that this part is only responsible for the horizontal gaze, not the vertical gaze. Okay. Now, if you get a damage in the parapontine reticular formation, then the ipsilateral side of sixth nerve won't be activated, and as a result, you won't get the contraction of the lateral rectus, right? So what happens is the eye will look away from the brain lesion. That means towards the side of hemiplegia you will get. Okay. Yeah.
Yeah.
Why is that? Because if this is your pons, okay, and this is your eye, let's say this is your right side again, this is your left side. The function of the PPRF, the right sided PPRF, will contract the right lateral rectus to make the eye look on the right side. If you get a lesion on the right PPRF, then the contraction won't happen. You will get the deviation of this eye on this side, right? So the eye will look away from the brain lesion. The eye will look on the left, which is away from the brain lesion, right? Towards the side of hemiplegia, because this side of the pons is controlling the left side, right? Are we good here?
Yeah.
Okay, just note that. Then the MLF, the function of the MLF is to contract the third cranial nerve. Okay, what you will get is the intranuclear ophthalmoplegia, because you guys know that the nerve impulses must be very fast in order to get a coordinated contraction of the right lateral rectus and the left middle rectus, right? And that is done by the MLF. If the MLF is not there, you won't get a coordinated gaze, right? And as a result, you will get the intranuclear ophthalmoplegia. What happens is, if this is your pons again, divided into two, you have this midbrain again, you have the eye. Cortex has sent a signal to the PPRF, which is this part. Now the function of this PPRF is to activate the right sixth nerve and to send a signal to my left-sided third cranial nerve by the MLF. These fibers are the MLF, right? If the MLF got damaged, the signal cannot be transmitted to my eye, to my midbrain, and as a result, you will get the contraction of your, let's suppose if this is your left side and this is your right side, you will get the contraction of your right eye, but you won't get the contraction of your left eye. And as a result, this eye will move, okay, but this eye stays there. Now, as soon as your brain detect it, okay, the brain will try to kind of, resolve this, right? And in doing so, you will see the nystagmus of this eye. Okay, you will see the nystagmus of this eye towards the opposite eye. Okay, so you will get the nystagmus of the contralateral eye with the abduction. Whenever you want a gaze, the abduction of this right eye happens. If you want to look on the right side, the abduction of this right eye happened, but the adduction of this left eye didn't happen, and as a result, the brain will detect it, and when the brain try to correct this condition, it will cause a nystagmus of this eye, okay, towards the medial side. Is that okay? Nystagmus is always opposite to the side of lesion, right? Which means in the direction of the correction, right?
Yes.
So that's what FC says here. In the internuclear ophthalmoplegia, you will have the impairment of the adduction of the ipsilateral eye, because the function of the MLF fibers is to activate the ipsilateral cranial third, right? So we'll get a nystagmus of the contralateral eye with the abduction. Does that mean your eye will get paralyzed? If you're having a damage of the MLF, you cannot activate your cranial 3 nucleus. That means you will have the down and out movement of your eye.
No, because the nerve is not getting damaged. Only one of the
Exactly.
signals. Yeah.
The nerve nucleus are normal. The cranial 3 is absolutely normal. It's just that at the time of gaze movement, you cannot get the gaze. Okay, but your eyes are absolutely normal. Okay, whenever you try to look from a single eye, it will be absolutely normal whenever you try to look something, right? But you cannot get the gaze. All the three structures, the frontal eye field, the PPRF, and the MLF, they are only responsible for the gaze movements. They will activate the nucleus, and then the nucleus do their job. But because the nucleus are not activating because of a damage of these structures, you won't get the gaze, right? But everything else would be absolutely normal. Okay, any doubt?
No, thank you.
And then you have the dominant parietal cortex, and whenever the damage of this dominant parietal cortex, which is usually the left-sided, okay, the left side cortex is usually dominant, and the right side is non-dominant type. Okay, the major regions are present in the dominant one, not in non-dominant, right? So whenever the dominant parietal cortex damage happen, and that could be happened because of any stroke in the MCA, that means the left MCA, right? You will get the Gesterman syndrome, in which you will get the agraphia, acalculia, finger agnosia, and left right disorientation. Okay, you won't able to identify what is your left side, what is your right side. You're unable to recognize the fingers by touching them, right? You cannot calculate anything. Okay, you cannot write anything. Okay, so the patient will be unable to write, unable to calculate, unable to recognize. Okay, and they will have the left right disorientation. Okay, this is the Gesterman syndrome. Gesterman syndrome. Okay. Then if the non-dominant parietal cortex get damaged because of a stroke or any kind of a tumor or anything, you will have the agnosia of the contralateral side of the world. That means if because generally it is your right-sided cortex. So whenever the damage of your right cortex happen, okay, you will have the complete neglect of your left side. Okay, the patient will bathe on the right side but not on the left side. Okay, the patient will recognize their right hand but not their left hand. Okay, so they will kind of they will have the neglection of all of their left side. They will recognize only the right side of their body, not their left side. Okay, so this is the hemiplegia, hemispastal neglect syndrome. Okay, you will get the neglect syndrome because of the non-dominant parietal cortex. So remember, for a dominant, you will get adjustment syndrome. For the non-dominant, you will get the neglect syndrome. Okay. Then you have the hippocampus, and I told you already, if you have a damage of the hippocampus, you will get the anterograde amnesia. And one of them is the transient anterograde amnesia, right? When the patient asks you what happened repeatedly, right?
Yeah.
That's because of the hippocampus damage. Then you have the basal ganglia responsible for your movements. If the damage happens, you can get the tremors at the rest. You can either get the chorea, you can get the acidosis. So you will get the Parkinson's disease. And does anyone know what actually happened in the Parkinson's disease? What neurons get lost?
Dopaminergic neurons.
Okay, right. And in the Huntington's disease,
Subthalamic.
subthalamic. Are you sure?
Purkinje cells.
It is a caudate nucleus which got damaged in the Huntington's disease, and the acetylcholine was lost, right?
Yeah.
In Huntington's. In Wilson's disease, you will be having a copper deposition in the basal ganglia. And if you guys go back to GIT, we have discussed that only in the Wilson's disease, you can have the damage of the basal ganglia because of the copper deposition, right? No other disease can do that. So the patient will get the Parkinson's-like symptom in the Wilson's disease. Okay. So the Parkinson's disease, you will have the inhibition or the destruction of the excitatory neurons, the dopaminergic neurons. So you will get the the tremors at the rest. You will get the rigidity, right? In the Huntington's disease, you will have the loss of ACH and the caudate nucleus. Okay, so that happens in the basal ganglia. Then you have the subthalamic nucleus, and whenever the damage because of function of the subthalamic nucleus is to inhibit my basal ganglia and to inhibit my movements, right? Because it is responsible for the activation of my GPI, and then the GPI will inhibit my thalamus. Remember?
Yes.
So with the damage of the subthalamic nucleus, you can have the contralateral hemiballismus, okay, which is a wild flinging type of movement of one side of the body, the contralateral side. Okay, very important. Then you have the mammillary bodies, okay, and if the damage to the mammillary bodies happen, you can get a Wernicke-Korsakoff syndrome, and we have discussed that already in the vitamin section. And what vitamin can cause it?
B1.
B1, thiamine, right? So you will have the confusion, you will have the ataxia, nystagmus, ophthalmoplegia, and mostly this ophthalmoplegia is the nystagmus. Patient will get the anterograde amnesia first, and then they will get the retrograde amnesia. And please note that the memory loss is always permanent. Patient will get the confabulation. They will try to make up the stories of their to fill their memory gap, right? They will get the personality changes also, and that's all because of the thiamine deficiency. Then you have the damage of the amygdala, and you will get a Clever-Bussy syndrome because of that. And you will get a triad of the hyperphagia. Patient will become, he will eat and just eat and eat and eat. So they will be very obese. Patient will get the hypersexuality, and they will get the hyperorality. They will touch everything with their mouth. They will try to eat everything, even a plastic. Okay, so this is the hyperorality. Hyperphagia, hypersexuality, and hyperorality. This is seen in the Clever syndrome. And please note, because the HSV1 encephalitis damage mostly your temporal lobe. So whenever you get any inflammation in the temporal lobe, always think about the HSV1 encephalitis. Okay, and if you get a bilateral temporal lobe inflammation, then you can be 100% sure that this must be a case of HSV1 encephalitis, right? And it will lead to the Clever-Bussy syndrome, damage of the amygdala, because amygdala is a part of your temporal lobe, right? Then you have the dorsal midbrain. And if you got a damage in the dorsal midbrain, especially your superior colliculus, okay, then you can have the vertical kind of, in this gaze palsy, vertical gaze palsy. Okay, and this is known as the Raynaud syndrome. And that happens because of a what kind of tumor? We have discussed that already while discussing all the brain sections, right?
Pinealoma.
Pinealoma, right? Whenever you got the pinealoma, because it presents just above my superior colliculus, the superior colliculus will damaged and you will get a vertical gaze palsy. Okay. And yeah, mostly to remember this. Okay, you cannot trace your eyes upward because of that, and this is a lid retraction you will get. Okay, and the leer light dissociation you will also get. Okay, and the convergence retraction nystagmus is also there, right? So it happens whenever you cannot trace your eyes upward. Okay, because you got the vertical gaze palsy because of this syndrome, because of the superior colliculus damage. Then you have the reticular activating system, and I told you that this reticular activating system present in the midbrain responsible for the consciousness, right? So if you got a damage of this RAS, you will get the loss of consciousness. You will get the coma ultimately, right? Then you have the cerebellar hemisphere. Whenever a damage happens, you will get the loss of balance. You will get the intention tremor. If you guys remember, ataxia will be there. Patient will fall towards the side of lesion. In case of a vermis got damaged, you will get a truncal ataxia, right? You'll get a nystagmus. Why nystagmus happen? Why nystagmus happen in the vermis damage? We have discussed that previously in the cerebellum part. Because of the foccular nodule. Because of the foccular nodular lobe, right? Because this lobe is lying in a very close association with this vermis. So whenever a damage of vermis happened, the foccular nodular lobe will also damage because of that. And this lobe is responsible for your balance and for your eye movement also. So you will get the nystagmus and you will get a truncal ataxia because of that. Okay. And you can get a damage of this vermis because of the alcohol also. So it would be a patient, they will show you a gross image of the cerebellum pointing at a side, and they will ask you in what kind of disorder this structure got damaged. So looking at the vermis, you will know that in case of a chronic alcohol, patient can get a damage of cerebral vermis, and that's the reason why the patient after drinking got very ataxic. Okay, they will fall towards other sides, right? Then you have the red nucleus, and I told you to remember the decorticate and the decerebrate portioning for the red nucleus. If the damage happens at the level of red nucleus, that means at the level of midbrain or above the midbrain, right? So you will get a decorticate this portioning, okay, which means you will get a flexion of both the you will get a flexion of the upper extremities and the extension of the lower extremities. Whenever you get any lesion below my red nucleus, okay, then you will get a decerebrate posturing, okay, and in that the patient will have an extension of both upper limb as well as the lower limb, okay. So in the decerebrate posturing, you will be having an extension both upper lower. In the decorticate posturing, you will be having a flexion of the upper limb and the extension of the lower limb, right? And this is located in the midbrain. So any doubt on this page so far?
No, thank you.
Okay, then you have the lesion of the temporal lobe. Okay, first you need to know what areas are present in the temporal lobe. You have the primary auditory cortex there. You have the Wernicke's areas. Hippocampus is there. Amygdala is there. Olfactory tract is there. Meyer's loop is there. Does anyone remember the Meyer's loop? What does it do?
Connects the Broca's to the Wernicke.
Broca's to the, oh no, man.
Sorry,
That
those
wasn't
were
the Meyer's
arcuate
loop.
fibers.
Yeah, those were the
Yeah,
arcuate
the
fibers, not the Meyer's
Meyer's
loop.
loop are there in the ophthalmic tract or optic tract.
Yeah, it is in the optic
pathway.
tract, right? Exactly, it is in the optic tract. The radiations of, after the lateral genic fluid body, which travels to my this temporal lobe. These are the Meyer's loop, right? We'll discuss that later. Okay, so don't forget that. Okay, so if you got a damage of the temporal lobe, you can get a damage in the primary auditory cortex. You will get a decrease in the hearing, or you will get a deafness. If the bilateral damage happened, you will get a deafness. If the unilateral damage happened, you will get the decrease in hearing. Because of the Wernicke's area damage, you will get the impaired comprehension of any language. Okay, you won't be able to follow any command. Okay, you won't be able to understand anything, right? The speech will be very fluent, very fast, fluent, but it will lack any meaning because the patient was unable to comprehend it, right? With the hippocampus, you can get the enterogram amnesia we have discussed. With the amygdala, you will get the Clever-Bush syndrome, right? Hyperphagia, hypersexuality, and hyperorality. Okay. Yeah, so that was the major areas. In case of olfactory tract, you will have a loss of any smell, and most importantly, you will lose any taste. Okay, because both smell as well as taste buds are required to taste any food. If you even got a loss of smell, you cannot taste anything, right? So the patient will complain you that the food is very tasteless. He cannot taste anything, and that means he have a damage in the olfactory tract. Okay, Mayor's loop, if got damage, you will get the chordentropia. Okay, that means a pie in the sky. If you guys remember that, anyone? We will discuss that. Don't worry.
Yeah.
You will get the chordentopia, okay, because of the Meyers's loop damage. So these are all the lesions of the temporal lobe. And how does you get a temporal lobe lesion? By a stroke. It could be a ischemic stroke. It could be a hemorrhagic stroke by any tumor, by any virus like the herpes virus, because you know that the herpes simplex virus 1, it will reactivate, it will cause the encephalitis of the temporal lobe. Okay. And does anyone know if this is a primary infection or a secondary infection or a reactivation of the herpes simplex virus?
Primary, I think.
Yeah, it is a primary
Primary.
infection of the, yeah, it is a primary infection of my herpes simplex virus. And that happens whenever you got the oral lesions. Okay, because of after infecting your oral cavity, the herpes simplex virus can enter into your this temporal lobe and can cause a temporal lobe encephalitis. Okay, so do remember these things about it. Okay, now you have the stroke. Okay, so you have the brain, okay, which is supplied by the blood vessels, and all this blood is very necessary for the brain to function. Wherever the loss of blood supply of any part or the complete brain occur, what you will get is the ischemia of the brain. And because of this ischemia, if this if the loss of blood supply become too much severe, even the infarction of that side of a brain can happen. And if the infarction of a brain happen, you will have the loss of function which is performed by that area, right? So what you will get is the loss of sensory impulses, loss of motor impulses, loss of these higher senses, right? So these are all the signs and symptoms of any stroke. It is nothing but just a loss of blood supply to a particular area of a brain, or sometimes a complete brain also. Okay. So before we go to that, you need to know that the stroke could be of two types. One is the ischemic stroke, and second is the hemorrhagic stroke. Okay. And before that, you need to know that stroke, either it could be a focal or it could be a diffuse. Okay. If the diffuse stroke happens, then complete brain will suffer. And the areas who have a very higher oxygen demand, or the areas that are watershed, they will die first. Okay.
Yes.
Are you getting my point?
Yes.
Okay. And how does you get a diffuse kind of a stroke? By any kind of a shock. Okay, because of loss of blood supply, by any kind of atherosclerosis indirectly they are in your carotid vessels, so you will get a loss of complete blood supply. Okay, so these are generally the lesions you will get the ischemic stroke, a diffuse kind of a stroke. Okay, now second is the focal stroke or the localized stroke that happens because of a loss of blood supply to a particular area of your brain, for say the Broca's area or the somatosensory cortex or a whole frontal lobe, a whole occipital lobe. Okay, so a particular area will die in that case. Okay, and these strokes are of two types, the ischemic or the hemorrhagic. In the ischemia, you will have the loss of blood supply because of any embolus or any atherosclerosis. Okay, and as a result, the blood supply to that particular area will be lost, and what you will get is the hypoxia, ischemia, and necrosis. Then you have the hemorrhagic stroke, and the hemorrhagic stroke occur because of a rupture of a blood vessel in a particular area that is supplying a particular area. Because of that rupture, this blood supply, this blood vessel cannot perfuse the organ anymore, that particular area anymore, and what you will get again, ischemia and death of that area. And in case of hemorrhagic stroke, the death of the area happened because of two reasons. One is ischemia, of course, and second is because of the pressure. because whenever the blood supply, whenever these vessels ruptured, okay, the pressure in that particular area will rise because of this leakage of the blood flow, right? And so the damage can be happen because of the pressure overflow and because of the ischemia, of course. Okay, now, so for the ischemic stroke, you have two types. Either one is a this transient ischemic stroke, okay, and second is the permanent type. In the transient ischemic stroke, as the name suggests, the ischemia happen for a short duration, okay, because of an atherosclerotic plaque or because of a vasospasm. Okay, so transiently ischemia happen and the symptoms will resolve after some time. Okay. In the complete ischemic stroke, you will have a loss of blood supply to the particular area forever, like due to any embolus, like due to any thrombus or any atherosclerotic plaque in that area. Okay. Then the hemorrhagic, you have two type of hemorrhages. Okay. One is the intracerebral hemorrhage and second is the meningeal hemorrhage. The meningeal hemorrhage can be epidural, subdural, subarachnoid. Just above your dura, after the dura, in between the dura and the arachnoid. Then after this arachnoid, that means between the arachnoid and the pia mater, and because pia mater lie in a very close association with your brain, so there is a very little or no space between the pia mater and the brain, right? So no hematoma or hemorrhage can happen after that. Okay, so hemorrhage can happen in the epidural space, in the subdural space, and in the subarachnoid space, and that is known as the meningeal hemorrhage. Okay, then you have the intracerebral hemorrhage, or you can say an intraparenchymal type of hemorrhage. Okay, whenever your these lacunar vessels, which are the vessels supplying the deep structures of your brain, the parenchyma of your brain get die, right? And as a result, the deep structures will suffer, and this is known as the intracerebral hemorrhage. Any doubts so far?
No.
Okay, and now in the next 4-5 pages, we will study all these hemorrhages and all these type of strokes. Okay. Now let's see what happens whenever you got any ischemia or a stroke of the brain. Okay. Now, just like any other tissue, hypoxia will occur, and as a result, first the reversible death of the cell will occur, and then the irreversible death of the cell will occur. Okay. So in the irreversible neural injury that begins after the 5 minutes of the hypoxia, within 5 minutes, you will have the irreversible death. And does anyone remember for the myocytes, what was the time for the cardiomyocytes to die irreversibly? In the myocardial infarction, what would be the time of irreversible damage?
More than 20 minutes?
It was 30 minutes, okay?
30 minutes, yeah.
So 30 minutes for my cardiomyocytes, and see the only 5 minutes you will have for my brain. So whenever you have a loss of blood supply only for 5 minutes, you will have the irreversible damage. The patient will have to suffer the consequences irreversibly, right? And if this hypoxia happen only for the 5 minutes, it resolves before the 5 minutes, what you will get is the transient ischemic stroke. Okay, the cell death will be reversible type, injury will be reversible type. Okay, and all the symptoms will be resolved after some time. Okay. Now, the most vulnerable areas are your hippocampus. Of course, you have the neocortex. Okay, you have the cerebellum, the Purkinje cells. Okay, and the watershed areas, they will have to suffer the consequences first, and then the later areas. Okay. Now, before you give any treatment for the ischemia or stroke to a patient, you first need to identify whether it is a ischemic stroke or it is a hemorrhagic stroke. That means whether the stroke is because of a leakage of the blood or because of a loss of blood supply, right? And after that, you have to decide your treatment. Okay. So first, you need to exclude the hemorrhagic type of stroke. Okay, because if it is a hemorrhagic type of stroke, then you need the clotting, and you cannot give the patient TPA, which is a plasminogen activator, right? You cannot give the patient that, because if you give the patient, it will further promote the hemorrhagic type of stroke. Okay. Now, the CT scan can detect the ischemic changes within the 6 hours. That means after, not within, but after 6 hours. Okay, but the MRI can detect the changes within the 3 to 30 minutes. Okay, and that's why the MRI is the test of diagnosis for the ischemia. So they will, so this MRI will tell you whether it is a ischemic stroke or whether it is a hemorrhagic kind of stroke. And based on the findings, you will have to determine your treatment. Okay. Now, whenever the cell death happens, what changes you can see on the microscope of the patient, you need to know that. Just like I told you, an algorithm, remember, whenever cell death happens, within the first 24 hours, you will only get the necrosis. Okay. Then after 1 day to up to 3 days, you will get the neutrophils. After 3 days, the macrophages will arrive at the location and they will determine whether to continue the inflammation or whether to resolve the inflammation. So after 3 days, you will be able to see the macrophages up to the 7 days or 14 days. After 7 days, the healing process will begin, right? So similar algorithm will follow here. Okay. Within first 12 hours, you cannot see anything. And that is the time when the edema of the brain will be happening, when the edema of the cell swelling will be happening. After 24 hours, the shrinkage of the neurons will happen. And what you will see on the histology is the red neurons because of the shrinkage of the neurons. We have discussed that already, right? You will have the loss of nasal substance, you will have the shrinkage of the neurons because of increased intensity and loss of membrane. The neurons will become red neurons, very eosinophilic, you will see. Okay. Now, after 24 hours, the neutrophils will arrive at the location, and when the neutrophils arrive, they will cause a necrosis. Okay, and in that case, it will be a liquefative necrosis. Okay, and the cavity where this and the area where this infarction occur, it will become a cavity filled with the liquid, right? The liquefative necrosis. Just give me a second. Sorry about that. Okay, so after 24 hours, the neutrophils arrive at the location and they will cause a liquefative necrosis. And the area which had a function to perform, now it become a cavity which is filled with the fluid, and that is the necrotic material. The dead cells will be there, dead neutrophils will be there, right? After 3 days, the macrophages will arrive at the location, and then they become, they start phagocytosing everything, all these dead neutrophils, all these dead cells. Okay, but please note that the recruitment of these macrophages is very slow. Okay, and as a result, you cannot have the healing process very soon in case of the ischemic stroke. So you will have the lesion for the lifetime. Okay, now only when the just give me a second. Okay, so after 3 days, the macrophages will arrive at the location. Okay, and then they will start phagocytosing everything, including the myelin. And if you look the microscope, okay, if you look the macrophages under the microscope, what you will see are the lipid-laden macrophages or the foam cells, because all of these macrophages will be filled with the myelin and the other lipids. Okay, so what you will see are the foamy macrophages after the 3 days of the stroke. Then after 1 week, okay, the astrocytes will arrive at the location. And the function of the astrocytes is to begin the healing process. They will cause the fibrosis of the area. They will cause the reactive gliosis, right? And you will get the vascular proliferation area. And it is that time, after 1 week only, you will be able to see that lesion with your eyes. That means a gross examination. On the gross examination, you will be able to see that area, that fluid filled cavity, only after 1 week. Okay, when the reactive gliosis happened. Are you getting my point?
Yes.
The microscopic changes will be visible after 12 hours, but any gross change will be visible after 1 week only. Okay, when the reactive gliosis happen.
Okay.
Yeah.
Yes.
And so after 2 weeks, what you will see is the glial scar. Okay, very important. So that's how, whenever the necrosis in my brain happen, that's how it will progress. Within first 12 hours, you cannot see anything. And that is the time when the swelling of the cells will be occurring. After 12 hours, you will be see only the shrinkage of the neurons. Okay, red neurons you will see. After 1 day, the neutrophils arrive, necrosis happen. After 3 days, the macrophages arrive. Okay, up to the 5 days, they will stay. After 1 week, the reactive gliosis happen. And that's the time when you have any cross change visible. Then you have the glial scar. Okay, and the inflammation will be continued throughout the life of the patient, because you can never have a complete healing in case of any ischemia or stroke. What are the general features? You will get the facial dropping, arm weakness, speech difficulty. Okay, and yeah, so these are the three features you will get whenever you got any stroke, and it is common for every stroke. So it would be a patient who was working on his office and suddenly started having this pain, and this paralysis of any limb, heaviness. They will say it, that they will have this heaviness of the arm. They will have this, they cannot say anything, they cannot talk. Okay, they try to call the ambulance, but they cannot because their hands are not functioning very well. Okay, so these kind of a history will be presented to you, right, whenever a patient get a stroke. Okay, and please note that these are the microglial cell, not the normal macrophages, because in the brain you have the microglial cell, not the normal macrophages. And the fibrosis in the periphery, you have the fibroblast for the fibrosis, right? In the brain you have the astrocytes for the fibrosis. Okay, no fibroblasts are present in the brain. Is that okay up to here?
Yes.
So far we have discussed what a stroke is. Okay, what different type of strokes are there, what you will see whenever you get any stroke in the microscope, what you will see. And now let's discuss the causes. Okay, so the ischemic stroke can be of three types. One is the thrombotic, second is the embolytic, and third is the hypoxic. In all of these strokes, you will get the liquefactive necrosis. Please note, we are discussing about the ischemic stroke, not the hemorrhagic one. Okay. Now, due to a this thrombotic type of stroke can happen whenever a atherosclerotic plaque, which is present in your brain vessels, it get ruptured. And because of it ruptured, it forms a thrombus there. And as a result, that complete branch, the blood supply from that complete branch will be lost. And the area of the brain will be dead, right? And the most common location is the middle cerebral artery. And because the last portion which is supplied by the blood vessels are their cortex, right? So you will get a pale infarct in the cortex of the patient. You have the cortex, you have the central part medulla, which is a white matter. Cortex is the gray matter, right? So the cortex will become very pale, because you know that most of the infarctions are the pale type. You only get red infarct and some locations only, like the testes, like the liver, like the lung, like sometimes the GI tract also, right? Is that okay?
Yes.
Then second, we have the embolic stroke. And if you guys remember, I told you whenever you have uh, any kind of arrhythmia, you can have the generation of embolus in it, right? Thrombus, and that thrombus will become embolus. It will become a systemic type of embolus. It can go to your brain. It can go to your any organ like kidney, GI tract, right? And it can cause the necrosis or cell death there, right? So if the patient has a history of this atrial fibrillation or any kind of arrhythmia, they are very high risk of developing the embolus. Similarly, endocarditis can do that. Whenever the vegetation dislodge from your valve, it will become the embolus, right? And in case of any This carotid artery stenosis, you will get that in case of deep vein thrombosis. And how we will get a deep vein thrombosis and then a systemic embolus because of that?
Uh,
Generally, in case of deep vein thrombosis, because it is a
Raman,
venous. Yeah, say.
Septal defects.
Yeah, any kind of subtle defect. It could be a foramen oval, it could be a
Raman
ASD,
only.
right? You will get a paradoxical embolus because of that, right? And one more disorder which Alfred didn't mention here, does anyone remember? Any other disorder in which you get a systemic embolus, and when you biopsy the embolus, you find it a tumor? It is the cardiac myxoma, remember?
Mixo,
In the cardiac myxoma, you will have the vegetation or a tumor on the wall, and then this tumor can dislodge from that area. It will become an embolus, right? It can cause a stroke. It can cause any kind of ischemia, necrosis in any organ, right? So one of the cause of the embolus is the cardiac myxoma also, right? Now, next one is the hypoxia. You will get the hypoxia whenever you got any kind of a shock. It could be a cardiogenic shock. It could be your anaphylaxis. It could be a septic shock. It could be a dehydration, right? So any kind of a shock can do the hypoxia. And because of the hypoxia, diffuse brain will suffer. The whole brain will suffer, not a single region, right? So whenever you got the hypoxia, you will have the global cerebral ischemia. Okay. And yeah, the watershed areas will die first. Okay. So these are the causes of the ischemic stroke. Okay. Any doubt up to so far?
no.
Okay. So we have discussed what is a stroke is. We have discussed what kind of strokes are there, and we have discussed the causes of the strokes here, ischemic strokes specifically. We have discussed what are the microscopic findings you will get in the patient when the patient die, because you can do the microscopy or the biopsy of the brain only when the patient die, right? And what changes you will see in the brain we have discussed. Now comes a treatment of the ischemic stroke. Okay. Now, before giving the treatment, you need to first identify whether it is a ischemic stroke or whether it is a hemorrhagic stroke. Okay, the first treatment would be the TPA. Okay, within the first 3 to 4.5 hour of the onset, if the patient has a symptom. Now, within 4 hours of the onset, you need to give the patient TPA. Okay, and you need to make sure that the patient do not have any risk of hemorrhage before that. Okay, if not the TPA, you can do the thrombectomy of the patient. Okay, and you will have to reduce the risk, the future risk of any kind of such events by giving the patient 2 drugs, the aspirin and the clopidogrel. Okay, you need to also control any other risk factor associated with the patient, like in case of diabetes, you need to control the blood sugar of the patient. In case of hyperlipidemia, you need to control the lipids by giving the patient statins. Okay, you need to control the BP of the patient, you need to control the smoking if they has any history, right? And if they have any history of atrial fibrillation, you need to treat that. Any kind of carotid artery stenosis, that means any atherosclerotic plaque in the carotid artery, if there, you need to treat it. And how can you identify the any plaque in my carotid arteries? What examination you will do?
Ultrasound.
Okay, ultrasound can help. Any simple examination? Very simple. Before any
Bruise,
test? Yeah, bruise.
auscultation.
Yeah, you will do the auscultation of your neck and you will have the bruise there. And that's how you know patient will be having any aneurysm or maybe any kind of a plaque there, right? And then you can do Doppler ultrasound. You can do the angiography, right? And then you will identify any lesion here. Okay. Then you have, this is a permanent type of stroke, because in the embolus will be permanent, thrombus will be permanent, and hypoxia will also be a kind of sometimes permanent. Then you have a transient ischemic stroke. Okay. And it happens for a brief period of time only. Okay. And the symptoms will be reversed. Okay. Because, this embolus will be present there only for less than 5 minutes. And because the embolus present there in less than 5 minutes, the symptoms will complete reversible, right? The cell will again regenerate because of that, right? So the patient will have a focal neurologic deficits, or they have the symptoms like the arm heaviness, weakness will be there, loss of consciousness will be there, right? and they cannot speak anything. Jaw dropping will be there, right? And that happens for only 15 minutes. Within 15 minutes, the symptoms will be resolved. So it would be a patient working very fine, and suddenly they had this attack where they have this paralysis of any limb, or a diffuse body also sometimes, if it is diffuse type. If it is a focal neurologic type, then you will look at the focal deficit. They will have this loss of any body movement. Okay, they will have this heaviness. They cannot say anything. They cannot hold any pen, right? They have this tremors. They have irregular breathing also sometimes. And all these symptoms resolve within the 15 minutes. And whenever you encounter such kind of a patient, you always first need to look for the carotid artery stenosis, because this is the most common cause of the transient ischemic attack. And when you identify this condition, if the patient is having any stenosis, then you need to give the patient aspirin, okay, and the clopidogrel, okay, and statins are also must therapy, okay, very important. So this kind of a things you will do. So arm weakness, difficulty speaking, okay, they all will manifest very suddenly, and they will resolve within the 15 minutes. Okay, so this kind of a thing you will get in the transient ischemic state. And because the condition is completely reversible, because no cell death is yet occurred, so the MRI will be negative. You need to also do the MRI to make sure patient is not having any kind of neurologic deficit, right? So these are the tests you will perform, these are the treatment you will do, okay, and this was the symptom of the patient. Any doubts so far?
No, thank you.
Okay, so that's all about the ischemic type of a stroke. Okay, and what symptoms you will get? The symptoms we have discussed on this page. All these symptoms can be there in case of any ischemia, right? The patient will get the loss of gaze, patient will get the Clever-Bussy syndrome, Painot syndrome could be there, embellismus could be there, right? Android amnesia could be there, agnosia could be there, Gentleman syndrome, hemi-neglect, anything can happen because of the stroke, right?
Yes.
Yes.
Okay, then you have the neonatal this intraventricular hemorrhage. Okay, so what happened? You first have the gemellar matrix in the fetus, right? They have the gemellar matrix, okay, that forms the neurons and the glial structures. Okay, the function of this matrix is to form the neurons and the glial cells, and this is a highly vascularized structure which is present in the ventricles. After 32 weeks, okay, this gemellar matrix, it become very less prominent. The vascularity of this gemellar matrix will decrease, and ultimately the atrophy of this portion happen. Okay, it just disappear from the brain after 32 weeks. But before 32 weeks, this structure is present, and it is a highly vascularized structure. So if a fetus born before 32 weeks, okay, then because of the presence of the gemellar matrix, they have a risk of the intraventricular hemorrhage. And as the name suggests, you have the blood accumulation in the ventricles. So you will get the hydrocephalus. A diffuse hydrocephalus will be there, and the ventricles will be filled with the fluid, as you can see. The ventricles will be filled with the blood. So it is a bleeding into the ventricles. Okay, the intracranial pressure of the patient will be rising. What symptoms you will get? You will get the increase in the head circumference. You will get the bulging fontanelles of the patient, right? So that will be the history of the patient. And the patient will be before 32-week gestation. This is a must thing. After 32 weeks, you cannot see this condition. Low birth weight can also be there, right? Gemellar matrix, which is a highly vascular structure present in the subventricular zone. You will have the altered level of consciousness, bulging fontanelle would be there, hypotension, seizures, coma, irregular respiration, decrease in the movement, hypotonia. All these things will be there. So just look for the hint patient before 32-week gestation, and now they are having these neurological symptoms. You will be immediately know that the patient is having a neonatal intraventricular hemorrhage. Okay. Yeah.
Yes.
Now you can also have a bleeding because of the child abuse, because of any head trauma. So how can you differentiate the condition of neonatal intraventricular hemorrhage with the shaken baby syndrome? Anyone? You have the bleeding in brain in both of these disorders, in both of these conditions. So how can you differentiate between the two? Anyone? Is it a gestation week? Yeah. Is it a gestation week, which will help you determine the cause? Please respond. Okay, so don't worry. Okay, in case of neonatal intraventricular hemorrhage, you will be having a hemorrhage within the ventricles. In case of a shaken baby syndrome, you will be having a subdural hematoma. The location of bleeding is important. Okay, if you get a subdural hematoma in a very little baby, a child, that means it must be a case of shaken baby syndrome. If you got a bleeding within the ventricles, that means it is a case of neonatal intraventricular hemorrhage. Now, is that okay?
Yes.
Yes.
So the location of bleeding is very important to identify, right? Now, along with that, the shaken baby syndrome can also have the fractures in the rib. Okay, they will have this subdural hematoma that we have discussed, right? And that happens because of a tearing of the bridging veins. We will discuss that later, don't worry. The patient will also have the rib fractures. Okay, so a patient which is very, a boy which is very, who is very lethargic, they have this bulging anterior fontanelle, they have the increased head circumference, having this hemorrhage. The retinal hemorrhage is very important, which is not seen in case of intraventricular hemorrhage. The retinal hemorrhages will be there. The patient will get the fractures of the rib, and that's how you know that this is a case of shaken baby syndrome. And generally, the parent will give you a very abnormal kind of a history that the baby just fall off from the bed, or and he just fall off from the stairs or while walking, right? So they will give you a such kind of a history which is not corresponding with the symptoms of the patient, and that's how you know that the baby is having the shaken baby syndrome. Okay, so history is very important, and all these 3-4 findings are very important to identify. Any doubt on this page so far?
No.
Okay, so we will take a short break and then we will discuss the hemorrhagic disorders of the brain. Okay.
Okay. Thank you.
Now, before we go to the hemorrhagic strokes, first you know about the layers of our brain. Okay, and for that I need to open a file. Just give me a second. Okay, so the outermost you have the skin. Okay, just after the skin you have the periosteum covering the bone, the skull, and please note that this periosteum fuses with the bone at the suture points. What I mean that you have the sutures in the brain. I hope everyone knows that, right? Sorry, not in the brain, but in the skull, right?
Yeah.
Okay, so let's suppose if this is a suture point, okay, then at this point, this periosteum will also fuse with the suture, right? So whatever fluid will accumulate here in between my bone and my periosteum, it cannot cross the suture lines. Is that okay?
Yes.
Okay, so you have the skin, then you have the periosteum. After the periosteum, you have the dura mater, and you have two layers of dura mater. One is the periosteal dura mater, and second is the meningeal dura mater. Okay, so as you can see, the periosteal dura mater lie in a very close association with your bone, and the and the meningeal dura mater. Okay, uh, in between these two layers, you have the sinuses, the venous sinuses. Okay, and as you can see that these are the arachnoid granulations, which will collect the blood in the the CSF within the arachnoid space, and will pour it or drain it into the venous sinuses. Okay, after the this dura mater, you have the arachnoid mater. As you can see, this is the arachnoid mater. Okay, and after the arachnoid mater, you have the subarachnoid space, and this is a space where your CSF run. Okay, and the blood vessels also are present here in the subarachnoid spaces, as you can see. And finally, you have the pia meter, right? So the dura mater, arachnoid mater, and the pia mater. Before that, you have the periosteum and then the skull. Now, different type of hematomas can found. Okay, hematomas can be present between the scalp and the periosteum. Okay, and that hematoma is known as the caput. Just give me a second again. Okay, yeah, if the blood is if the blood is accumulated in between my skin and my periosteum, okay, then you call it a caput hemorrhage, as you can see, right? So this is a blood accumulation between my scalp and between my periosteum. And as you can see, because my scalp and periosteum are not fused with the bone, this type of hematoma or this caput hemorrhage can cross the suture lines. Are you getting my point?
Yes.
So this kind of a hemorrhage can cross a suture line if it is present in the frontal bone, then it can cross suture line and will be present in the temporal lobe or the parietal lobe, right? So ultimately, because of the gravity, it will all come down, okay, and start accumulating near your temporal lobes, this bone, right? So this is the caput hemorrhage, okay, and it can easily cross the suture lines. It could be bilateral, okay. A unilateral hematoma can become bilateral, okay. So this kind of a presentation will be present. Now, between the periosteum and the skull of the bone, you have the subperiosteal hematoma or hemorrhage, okay, as you can see here. And this is known as a cephalatoma also, okay, that happens between the periosteum and my skull. And because my periosteum is fused at with my skull at the suture points, this kind of a hematoma cannot cross the midline, okay. If it is present in the frontal lobe, then it will present only in the frontal lobe. It cannot cross the suture lines, right? And yeah, so these two types are very important. And whenever you have these two type of hematomas, it will present as a bulging in your scalp, okay. It will present as the bulging. After that, whenever you have any hematoma, the diffuse kind of a swelling will be present in your brain, okay. So whenever you have a bulging at any portion of your skull or brain, you will think about these two type of hematomas, okay, the caput succedaneum or might be a cephalatoma, right? And in that case, you need to determine whether the this hematoma is crossing the midline or not, sorry, the suture lines or not, right? So after that, you have the epidural hemorrhage, the subdural hemorrhage, the subarachnoid hemorrhage, and finally the intraparenchymal. Okay, the epidural hemorrhage is present between the skull and my periosteal dura mater. Okay, then you have the subdural hemorrhage, which is present here. Okay, in between sorry, the epidural hemorrhage is present. Yeah, epidural hemorrhage is present between the bone and my dura mater. The subdural hemorrhage is present between my dura mater and my this arachnoid mater. Okay, and then comes my subarachnoid hemorrhage, which is present between my arachnoid mater and my pia mater. Okay, and then finally you have the intraparenchymal hemorrhage, which is present within my brain. Okay, is that clear up to here?
Yes.
Good. So now let's go back to the first slide. Okay, so three above two we have discussed already, cephalatoma and my caput succedaneum, right? Now you have the epidural hematoma. Okay, and that happens because of a rupture of the middle meningeal artery. And does anyone remember from where does this middle meningeal artery enters my skull or my cranium? Which foramen? No one?
Spongiosum. Spongiosum.
Say it again, please.
Spinosum.
Yeah, it is a
Yes.
spinosum. Foramen is spinosum. Okay. So from the foramen spinosum, my blood will enter in my cranium. This blood vessel will enter the cranium. Okay. And please note that this middle meningeal artery is a branch of my maxillary artery. Okay, and this artery will be ruptured at the pterygium region, which is the thinnest part of your skull, and at that portion, the the frontal bone, temporal bone, sphenoid bone, they all meet at that point. Okay, and this is the thinnest point of my skull. So whenever a sudden trauma happened, at that point, I will get the rupture of my maxillary artery, which is the middle meningeal artery, which is a branch of my maxillary artery. Now, because of that, you will be having a hematoma between my between my bone and my dura mater, right? And as you can see, this is kind of a fracture. This is a region of the region, right? And this is a fracture happening, right? And after that, you'll be having a hematoma, right? As you can see here. And this kind of a hematoma present as a lens-shaped mass. As you can see, this is a kind of lens-shaped mass you can see. And a very well demarcated borders are there. Okay, these are very important. And this kind of a hematoma, it cannot cross my suture lines. And because it cannot cross my suture lines, it cannot be bilateral. Okay, very important to note. It cannot cross suture line and it is present as the lens-like mass. Okay, the patient first they will lose the consciousness after the rupturing of this artery. Okay, then they will have a recovery. Okay, where they suddenly wake up from that consciousness. Okay, and this is known as the lucid interval. They remember everything, but actually they're very much confused. Okay, that what happened to them. Okay, they will become suddenly conscious, and then again they will have the rapid deterioration. Okay, due to the hematoma expansion. Okay, so first the loss of consciousness, then again the gain of consciousness, but with a disorientation, and then again a loss of consciousness. So this kind of a presentation will be present in case of epidural hematoma, whenever the patient has the blood accumulation between the skull and my dura mater, right? So, and please note, because this dura mater will ultimately fuse with my suture lines, with my sutures, right? So it cannot cross the suture lines. It will be shown as the hyperdense mass, as you can see. This will be seen as the the ischemia. Let me go back. Yeah. Ischemia will appear as the hypodense mass. As you can see, a very darkened mass is there, very dark region, right? This is the hypodense mass you can see. Okay, and the hemorrhagic kind of stroke will appear as the hyperdense mass on the CT or MRI. Is that okay? That's how I will identify the kind of stroke happening to my patient. Okay. Now, as the hematoma expand, as the blood start filling in this space, the intracranial pressure will rise. And because you guys know that there's a very little space present between the brain and and the cranium, right? It has almost no space for any further accumulation of any fluid or something like. So whenever the mass is filling up this space and the intracranial pressure is rising, what can I have? The herniation of my brain. And whenever the brain herniation occur, in this case, you will get the compression of the cranial nerve 3. And in this case, okay, first my Edinger-Westphal nucleus will die. I will get a very full-blown kind of pupil. And then my motor nucleus will die and it will cause a down and out movement of my eye. Along with the herniation and this increase in the intracranial pressure, you can again got one condition which is known as the Cushing triad. Remember?
Yes.
What does a Cushing triad is?
Hypertension, bradycardia, bradypnea.
Yeah, you will get the hypertension, you will get the bradycardia, and you will get the bradypnea because of that. So whenever you encounter a patient with any kind of a head trauma history, like in case of epidural hematoma, okay, and the patient was having this a very low heart rate with high BP, and he's having a very irregular kind of breathing, and that's how you immediately know that the patient is dying because of the herniation of my brain. Is that okay up to here? The epidural hematoma.
Yes.
Okay. Now you have the subdural hematoma, and this kind of a hematoma can cross the suture lines because it is not fused with the sutures, right? It happens because of the rupture of the bridging veins. Okay. Now what happens? You have some space between the cranium and the brain. Actually, if I draw it, so if this is your cranium, okay, then you have this brain here, right? This structure is my brain. Now, if the space between the cranium and the brain is increased, then you have some bridging veins here. Okay. If the space between the my cranium and my brain increased, then the tension on these bridging veins will be increased, right?
Yes. Yes.
And when the tension between these bridging veins increased, what you can end with a slight a trauma, okay, with a sudden kind of acceleration or a de-acceleration injury even, okay, patient can get a rupture of these veins. And when the rupture of these veins occur, what's going to happen? You will have the subdural hematoma. And please note that this condition most commonly seen in the either the old age patient. Yeah. This condition either can see in a very old age patient, because in very old age you will have the atrophy of the brain, and because of that atrophy you will be having an increased space between the cranium and my brain. And this condition can also be seen in the newborns, because in the newborns they have a very immature, very little brain, so they have a very increased space between the cranium and the brain. So these two population are at very risk of getting the subdural hematoma, and that's why in the old age you will get the repeated episodes of the subdural hematoma also. Okay, my grandmother had this hematoma. I think 2 or 3 hematomas she currently has, right? So it is a very common condition in the old age. Okay, now, so it is because of rupture of the bridging veins, and that happens because of a traumatic or a high energy impact. Okay, it will be appear as a hyperdense mass on the CT, as you can see. It will be expanding type of mass. Okay, it can also be very much chronic. Okay, the patient can have one hematoma, it will resolve, then patient have another hematoma, it will resolve, then patient have another hematoma. So multiple hematomas can be present on a one patient also, right? It could be associated with the mild trauma, the cerebral atrophy, elderly, because in case of elderly, you will be having a cerebral atrophy. Alcoholism can do that. You will have a hypodense mass along with a hyperdense mass on the CT. As you can see on this D, right? You're having this both, this multiple type of hematomas are there, as you can see, right? Both a hypodense mass is present as well as a hyperdense mass is present, right? So these kind of things can also sometimes happen. It can also be seen in the shaken baby syndrome, because please turn off your mic. I did that. Okay. Now, this can also be seen in the babies, because the baby have a very large space between the cranium and the brain. So their veins are at a very high tension. They can rupture, okay, in case of a shaken baby syndrome. So the predisposing factor is the brain atrophy and the trauma. What you will find is a crescent shaped mass, the C-shaped mass you can see here. Okay, and this mass can cross the suture lines. It is not bound to the sutures, right? Very important. Then the patient can also have the midline shift of the structures. As you can see, if I draw, this is my midline. And as you can see, the patient is having a shift of the midline structures, right? Because of the increase in the pressure. Okay. So these kind of things will be seen on the CT of a patient having the subdural hematoma. And because you have the veins, and veins are having very little pressure in them, okay, the blood will be flowing at a very little pressure, right? So this hematoma will very, this hematoma take very time to expand, unlike my this artery hematoma, because artery have a very high pressure fluid, right? So this hematoma have very time to expand. So the patient will be having the deterioration of the symptoms at, of these symptoms at a very large time. Okay, they will have a symptoms are very gradual onset. The symptoms are a very gradual in onset. Okay, and this can happen with a very minor trauma in the elderly. Okay, because of an increase in tension between the bridging veins. So patient will have a herniation, but at a very later stage. Okay, after like weeks or after months, they can have the herniation, not acutely. Okay, symptoms will be present at a very old age or a very early stage, right? but the symptoms are very gradual on the onset, unlike the acute in case of this epidural hematoma. Patient can also get the Cushing's triad, right? They can have a high increase in the intracranial pressure. Headache will be there, right? And yeah, that would be everything. Any doubt?
No, thank you.
So how we identify these type of hematomas? First, look for the landscape mass or the symptoms. The onset of the symptoms will be very acute. In case of subdural this hematoma, you will be having a very chronic type of symptoms. With this kind of a crescent mass, sometimes you can have a multiple hematomas. One is a hypodense, which is basically a resolved hematoma, then a new hematoma, which is the hyperdense. Okay, multiple kind of things will be there. Then you have the subarachnoid hemorrhage, and if you go back, the larger arteries of your brain, these are present in between the subarachnoid space. Okay, all these larger arteries, okay, like the middle cerebral artery, the anterior cerebral artery, right? They all are present in the subarachnoid space. The smaller arteries like the lenticulostriate vessels, that means a branch of these arteries, okay, they are present in the parenchyma of the brain. Are you getting my point? The larger arteries present in the subarachnoid space, and the branches from these arteries supplying a deeper structures like the basal ganglia, they are present in the parenchyma. So whenever you have a stroke involving the MCA or the ACA or the PCA, that means the stroke will be in the subarachnoid space. If you get a stroke because of the smaller vessels like the lenticulostriate vessels, you'll be having a stroke in the parenchyma of the brain. Is that okay?
Yes.
So now let's go back. And you also know that the CSF is also running in the subarachnoid space, right? So the subarachnoid hemorrhage can happen because of a trauma, because of a rupture of an aneurysm, like a case of saccular aneurysm. We will discuss that later, don't worry. It can be happen because of a arteriovenous malformation. Whenever a AV fistula formed, it can get ruptured and the blood will be within the subarachnoid space. When an aneurysm happen in a larger arteries, it can get ruptured. The blood will be in the subarachnoid space. Okay. Now, the patient will complain you with the worst headache of their life. That is the first thing. Okay, they will be a very, it is a worst headache. You can say that. Okay. Then because the blood is mixing with the CSF, okay, all this bilirubin and all this hemoglobin will be mixing with the blood. What you will get is a xanthochromia on the lumbar puncture. Okay. Damage can be happen because first of the ischemia, and second because of the pressure injury, because of an acute rupture of these vessels. Okay, because of the high pressure, the cells can die, right? So that is the thing happening in this subarachnoid hemorrhage. Now, once the hemorrhage happens, the your body will try to compensate it, right? Your body will try to stop it, the bleeding, and in that case, patient can have a vasospasm. You won't get any focal neurologic deficit because of the subarachnoid hemorrhage. And that is the most important thing. You got a patient who is having, you must know that the patient is having a hematoma, a hemorrhage is there in the brain, but the patient won't be having any kind of, these focal neurologic deficits. But when you encounter a patient with the hemorrhage along with the focal neurologic deficits, you will know that this hemorrhage is not in the subarachnoid space, but in any other parenchyma or any other area. Okay.
Okay.
It will just be a patient with a worse history of headache, and he's all working fine. His body parts are completely working when he admitted to the hospital. Now, after 3 days, vasospasm can occur. Now, when this vasospasm occur, now the ischemia can develop. And at that time, patient can develop the focal neurologic deficits. That means the weakness or the paralysis of one limb or one part of the body, the part where the structure of brain was supplying. This part will die because of the ischemia, because of the vasospasm, and that happens after the 3 days. So it would be a patient who presented to your department with a history of the subarachnoid hemorrhage. He do not have any focal neurologic deficit at that time. You admitted the patient. After 3 days, the patient will start having these FNDs, and that's how you know that the patient is having a vasospasm. Is that okay?
Yes.
And how will you treat that condition? You need to give the patient calcium channel blockers. That means a nimonidipen. Okay. Now, this is the risk that happens after 3 days. Okay. At the time of presentation acutely, patient can have other complications also, right? Like the hydrocephalus, because you know that all this blood is mixing in the CSF. Ultimately, the CSF need to be absorbed by the veins, and that's done by the arachnoid granulations, right? Now, because of this hemolysis of the RBCs, the inflammation in the CSF happen, and because of that inflammation, the scarring of the arachnoid granulations can occur, and that can lead to the inhibition or of the CSF. Absorption of the CSF will be inhibited, right? And what you will get is the communicating or sometimes a non-communicating hydrocephalus. Is that okay? You will get a diffuse ventriculomegaly.
Yes.
Now, because of the inflammation in the CSF, in the subarachnoid space, you can also get the neck rigidity or the neck stiffness, just like the meningitis, because of the meningeal irritation. Okay?
Okay.
Because in the meninges, the neck stiffness is nothing but because of the inflammation of the meninges. Same thing is happening in the subarachnoid hemorrhage. Rebleeding can also happen, and that happens within the 24 hours of the patient. Okay, and when you do the CT of the patient, you will show the accumulation of new blood. Right, so within 24 you can have the rebleeding. After 3 days you can have the vasospasm. Okay, so a sudden onset of headache with nausea without any previous history of similar attacks and without any FND. That means it is a case of subarachnoid hemorrhage. Patient can have a nuchal rigidity, patient can have a fever, they will have the meningeal irritation, headache will be there, right? Rebleeding can occur, okay? And hydrocephalus can also occur. After 3 days, vasospasm can occur. Causes: trauma, aneurysm, and the AV malformation. Please remember these 3 causes for the subarachnoid hemorrhage. And as you can see, the blood is accumulating in the subarachnoid space because this space is present in every part of your brain. As you can see, all these linear like structures will be formed, right? These are the subarachnoid spaces. Any doubt in the subarachnoid hemorrhage?
No, thank you.
So in
And now finally,
vasospasm, there are,
yeah,
excuse me, in
yeah.
vasospasm, there will be arterial and venules all get spasm.
Mainly the arteries are responsible for the vasospasm, right? Not the veins. The vasoconstriction
Yeah,
happen in the arterioles.
so the etiology of it, like why there is a vasoconstriction, because they want to prevent the bleeding.
Because your body want to prevent the
Uh,
bleeding, right?
yeah. So
And that
because
could be
of
done
that,
by
right?
constricting the vessels, right? So because of that, you can get the
So
ischemia, infarction.
mhm.
Yeah. Ask.
Okay. So and there is a CT, like the CT, the early onset they won't show in CT because here it's written um, shows no CT changes, like something 3 to 12
Sorry, I
days
didn't get.
after.
Yeah.
It is highlighted in pink, and the button line is written 3 to 12 days after subarachnoid hemorrhage, and CT is normal, like, so because it's get absorbed and there is no changes, right?
Sorry, I didn't get your question. If you can please repeat it again.
Could you please focus on the CT, like how will be the CT will be displayed if it will be done in
It will be a
sub.
blood accumulation in the subarachnoid. It will be a blood accumulation within the subarachnoid space. And as you can see, all these linings, right? These linings, if I focus, these things, these widest lines you see,
Mhm.
right?
Yeah, yeah.
All these areas, because these are the sulci of the brain.
Mhm.
All the sulci of the brain, they will be filled with the blood, right?
Mhm.
So at the periphery, in the center, you will get the blood accumulation within the sulci of the brain. And
Mhm.
that's exactly what you will see on the CT of the patient.
Mhm. So after 10 to 12 days, it won't be there, and it will be come with the vasospasm
Yeah,
after 3 to
exactly.
4 days.
When after the vasospasm, you will get the hypodensity because of the ischemia.
Okay, okay,
Okay,
okay.
and it would
Thank
be a
you.
particular area of the brain that will die. So it will be a hypodensity of a particular area of the brain that will die because of the vasospasm. Okay.
Okay, thank you. Thank you.
Okay, now you have the intraparenchymal hemorrhage that happens within the parenchyma of the brain. Okay, And that happens because most common cause is systemic hypertension. Whenever you have a patient with, sometimes with the hypertensive emergency, okay, with a history of end organ damage, they can either get a stroke in that end organ damage. So the most of the patients, they have the history of hypertension, right? Amyloidosis can do that because you know that the amyloid always deposit around the blood vessel. They will make the blood vessel very weakened. Small blood vessels can get ruptured and they will get the amyloid angiopathy, right? It generally happen in the elderly because in the elderly you have the increased risk of the amyloids, right? Vasculitis, the inflammation of the blood vessels can do that. Neoplasms, whenever you have any, it can cause the intraparenchymal hemorrhage because the neovascularization will be there. Any kind of cavernous hemangioma, okay, any kind of a blood vessel tumor, if happens, it will cause the hemorrhage within the parenchyma of the brain. Okay, reperfusion injury can happen because whenever you try to perfuse that area of the body or that area of the brain, the reactive oxygen species can form and it can cause further damage, right? You can get the Charcot-Bouchard aneurysms, okay, and these are also seen in the hypertensive hemorrhages, okay. And the most common vessel that get ruptured because of that are the lenticulostriate vessels. Now, what happens because of the systemic hypertension? You will have the lipohyalinosis, microatheroma, and the arteriolosclerosis. Okay, these three things will happen. You will have the formation of atherosclerotic plaque. Okay, you will have the atherosclerosis, you will have the arteriolosclerosis, and that makes the vessel very much weakened, right? These vessels will get ruptured, and lenticulostriate vessels supply the deeper areas of the brain like the basal ganglia, right? And as a result, the thalamus, pons, cerebellum, right, or subthalamus, caudate nucleus, these areas will have to suffer the consequences, the putamen, the basal ganglia, right? These area will die. You will get a loss either because of a damage of thalamus, either you get a complete sensory stroke, that means a loss of senses of one side of the body completely, or you will get a complete motor stroke. That means a paralysis of a complete part of a body, a side of the body, not a part, but a side of body. The internal capsule can die because of the lenticulostriate vessel hemorrhage. And you know that all the motor fibers, they run from the internal capsule, right?
Yes.
So because of that damage, you will get a complete loss of all the motor activity on one side of the body. And as you can see, this is what it looked like, the intraparenchymal hemorrhage. As you can see, the hemorrhage is involving only a part of the brain. The hyperdensity will be showing in the part of the brain. Similarly, if you get the ischemia of the lenticulostriate vessels, you will get the hypodensity instead of this hyperdensity, right? So this is what it looked like, the intraparenchymal hemorrhage. Is that okay?
Yes.
So now any doubt on this page?
Oh, thank you.
So how can you identify whether the patient is having a Charcot-Bouchard aneurysm or a saccular aneurysm? That means a Barry aneurysm. How you can differentiate between the two? By looking on the symptoms of the patient. I'm having the subarachnoid hemorrhage. In that case, I'm having the saccular aneurysm. I'm having a Charcot-Bouchard aneurysm, and that can lead to the intraparenchymal hemorrhage. How you can differentiate between a saccular aneurysm and a Charcot-Bouchard aneurysm based on the symptoms of the patient?
Neck rigidity.
Headache, severe headache and subarachnoid hemorrhage.
Both headache will be present in both the intraparenchymal hemorrhage as well as in the subarachnoid hemorrhage. Not a definitive thing.
Neck
The
rigidity and
intensity,
Okay, negativity could be a one thing, but it is not always present because it is a complication. It is not always there. What thing which is always there whenever you get either of the hemorrhage?
Headache.
xanthochromatia.
Xanthochromatia, well, you have to perform the lab test, then you will get it based on symptoms only. Looking at the patient, headache will be present in both of these conditions. Whenever you get any hemorrhage in the brain, it will present with the headache, of course. Headache will be present in any of the four disorders we have studied. Any kind of ischemia, any kind of hemorrhage will cause the headache. Now, I told you
Neurological
already.
deficits.
Focal neurological deficits, exactly. In subarachnoid hemorrhage, please remember you won't get any FND. It's just a headache sometimes fever and neck rigidity. Okay. In case of intraparenchymal hemorrhage, as you can see, a part of my brain is dying. So the structures which are, which are supplied by this part, they will die also. So patient will get the focal neurologic deficits because of that. So presence of headache along with FND. Think about the intraparenchymal hemorrhage. Presence of just the headache. Think about the subarachnoid hemorrhage. You don't need to perform any test. Okay. Based on the symptoms, you can get what a patient is having, right?
Yes.
Yeah.
So just remember that. Now, any doubt on this page now?
No, thank you.
Okay, so these are the layers I was talking about. You will get a caput succedaneum if it, okay, and you will get a subglial hemorrhage. You will have a syphilotoma. Okay, the caput succedaneum happens whenever you got a damage within the scalp itself. Then you have the subglial hematoma. Then you have the skull. Then you have the syphilotoma and all these things, right? So do remember that. Subglial hematoma is very important. Yeah, it happens between the periosteum and the glia aponeurosis. Okay, which is a subglial space that is between the scalp and my periosteum. It happens because of a damage to my emissary veins. Okay, and generally happens because of a vacuum assisted delivery. Okay, the baby will always have a history of vacuum assisted delivery. Okay, then you will get this kind of a hematoma. It will present as a bilateral swelling. Okay, and that swelling can even extend up to the neck because it can cross the suture lines, right? This is syphilotoma. Okay, so up to now we have discussed what a stroke is, what different type of strokes are there, what will be the microscopic profile you will get, okay, the cross changes you will get. Then we have discussed the cause of ischemic stroke. We have discussed about a transient ischemic stroke. We have discussed all the causes of my hemorrhagic stroke. Now, what are the symptoms you will get whenever you get any of these type of stroke, whether it is a hemorrhagic stroke or whether it is a ischemic stroke? What are the symptoms? So if you got a damage of the middle cerebral artery, okay, because you know that this artery is supplying the very very lateral structures of your brain, right? The peripheral portion of the brain supplied by this artery. You will get, and you know, if you look for the homunculus, you will see that at a very periphery, you have the face and the upper limb, right?
Yes.
So because of the damage of my MCA, you will have the paralysis of the upper limb as well as the face, the contralateral, I must say, right? The temporal area is also supplied by the MCA. The Wernicke's area will die, Broca's area, because it will present more laterally. It will die of that because, right? So the patient will have a, because of the upper and lower limb, because of the upper limb and the face senses and the motor damage, you will have the contralateral paralysis and the sensory loss of the face and the upper limb. Because of the Wernicke's area, you will have the this fluent type of aphasia, right? It will be a Wernicke's aphasia. The patient will have a very fluent uh, speaking, but their words just lack any meaning. Okay, so this kind of a thing will be there, and because the temporal lobe also contains a Mayer's loop, right?
Yeah.
And if the MCA dies, the Mayer's loop will also die because the Wernicke's areas and the Mayer's loop are lie very close to each other. So whenever you get the Wernicke's aphasia, you also have the visual field defect present, which is a superior chordentopia, pie in the sky, right? Along with the Wernicke's aphasia, you will also get the superior chordentopia, right? Because of the MCA. Okay. Then you have the Broca's area, which is an expressive type of aphasia. You cannot express your words. You want to say something, but you just can't. Okay. So because the MCA also supplying the parietal lobe, if the dominant parietal lobe damage, that means if the left MCA is involved, you can have what is known as a Gesterman syndrome. Okay. If the non-dominant parietal lobe die, that means if the right-sided MCA is present, you can have the hemi-neglect syndrome. Okay.
Yeah.
So these are the things which are present with the either the left MCA stroke or with the right MCA stroke. And please note that the Wernicke's area and the Broca's area, they are present in the left side of your brain, the left cortex, right? So only in case of left middle cerebral artery damage, you can get the aphasia because of that. Okay, not in the right sided.
Yeah, yeah.
Okay, good. So now in case if you get a damage or ischemia in the anterior cerebral artery, you will have the involvement of the lower limbs first, because if these are present, if you look at the homunculus, okay, these part will be supplied by the central portion of my brain, right? So the motor and the sensory loss will happen in the contralateral lower limb. It will be a contralateral paralysis with the sensory loss of the lower limb, urinary incontinence, because you know that the mixation inhibition will be done with the cortex, so the patient will get the urinary incontinence. Okay. Then you have the lenticulostriate vessels. We have discussed, to supply the deeper part of your brain, like the thalamus, like the internal capsule, like the other part of the basal ganglia. So you can either get a complete paralysis of one side contralateral part of your body, or you will get a complete sensory loss of one part of your body. Okay. But the cortical signs must be absent, like the aphasia or the hemi-neglect, or the visual field defects, right? They must be absent. And please note, the upper limb, lower limb, face, abdomen, complete part will be paralyzed or sensory loss happen, hemiparesis. Okay, not just the upper limb, or not just the lower limb, or not just the face, but complete one side of the body will be paralyzed because of that, if you get a lenticulostriate vessel damage. Are we good here?
Yeah, yeah.
So that happens whenever you have a damage in the anterior circulation, which means the branches of my carotid, internal carotid artery. Okay. Then you have the posterior circulation, which is presented, which is supplied by the what arteries?
Posterior cerebral artery.
Posterior cerebral artery.
Posterior cerebral artery. It is a branch of some artery, not a just major
Vertebral.
artery, right? Vertebrobasal artery, right? Vertebrobasilar artery. Okay. So you have the antispinal artery, the posterior inferior, the pica, and the ica. If you go back and look, there you have the vertebrobasilar arteries. Okay, they first give the pica, then they give the antispinal artery, then they before joining they give the ica, they joined and they give the basilar artery. Basilar artery gives short pontine branches. After short pontine branches, you will have the superior cerebellar artery, and finally you have the posterior cerebral artery, right?
Yeah.
So now what happens? Look, the anterior spinal artery supplying the anterior region. Okay, the posterior inferior cerebral artery and the anterior inferior cerebral artery supplying the posterior region of the brainstem. Is that okay?
Could you please repeat?
The anterior spinal artery supplying the anterior part, the basilar artery. If I go back again, the basilar artery and the anterior spinal artery supplying the anterior part of my brainstem, anterior portion of my brainstem.
Yeah.
And the pica ica supplying the posterior portion of my brainstem.
Yes.
Okay.
Okay.
With pica supplying the posterior part of my medulla, and the ica supplying the posterior part of my pons.
Yes.
Now, if you know that, then you easily know what symptoms patient gonna have. Because of the antispinal artery, which is supplying the anterior portion, and the anterior you have the corticospinal tract, corticobulbar tract, and the medial lemniscus pathway, right?
Yeah.
So what you can have, you will have the damage of the corticospinal tract, you will have the medial lemniscus damage, you will have the caudal medulla damage also that contains the hypoglossal nerve. Okay, because you know that the hypoglossal nerve present in the anterior damage only, right? The motor central part will be die, right?
Yeah, yeah.
So because of the corticospinal tract damage, you will have the contralateral hemiparalysis, and it will be a complete upper and the lower limb damage, just like my this lenticulostriate. But in the lenticulostriate, please note, no cranial signs are present. If the cranial signs are present, you will always go for the brainstem lesion. If the cranial signs are not present, you will go for the lenticulostriate. Okay, with a complete paralysis of one part of the body. You will have a decrease in the proprioception of the contralateral part, and whenever the proprioception are lost, you will have known as the Romberg sign positive. Okay, you will do the Romberg sign for the proprioception. Whenever it is lost, you will have a positive Romberg sign. Okay, the hypoglossal nerve get damaged, and as a result, you will have the tongue deviation towards the ipsilateral side. That means the side of lesion. Okay, and this is known as the medial medullary syndrome. Okay, then you have the lateral medullary syndrome, and that happens because of a damage in the posterior inferior cerebral artery, the pica. Okay, more lateral structures will die because of that. In the lateral, you have the nucleus ambiguous. Remember, in the medulla, you have the nucleus ambiguous, you have the dorsal vagal nucleus, and one more nucleus.
Nucleus tractus solitarius.
Nucleus tractus solitarius. And what is the function of my nucleus tractus solitarius?
Taste sensation, visceral sensations.
What sensations?
Visceral
Visceral
sensations.
sensation.
Visceral sensations, right? You will get the baroreceptors, you have the taste sensations, you have the sensation from my GIT, right? And after that, it will transmit the impulses via the dorsal vagal nucleus, right? You have the nucleus ambiguous for eating, right? For solving something. 9th, 10th, and 11th nerve take part in it, right? So when the nucleus ambiguous die, because it is present more laterally, you will have the dysphagia, you will have the hoarseness, you will have the decreased gag reflexes. Okay. Now, because of the vestibular nucleus damage that contains the nerve 8, and because it is a sensory nerve, it is present most laterally, right? So it will also die along with that. You will have the, and please note that the 5th and the 8th nerve, forgot to mention, 5th and the 8th nerve, they will die in both the pica and the ica, in the pons lesion as well as in the medulla lesion, right? I told you already.
Yes, yes.
So the vomiting, vertigo, nystagmus, it is present in both my pons damage, the lateral pons damage, as well as my lateral medulla damage. Okay. Now you have the spinothalamic tract, it will get damaged. So pain and temperature loss. You will have a loss of sensations of the ipsilateral face because of trigeminal nerve damage. Sympathetic fibers, okay, they will also die. You will get the Horner syndrome, ipsilateral side. Okay, you will have a damage of the cerebral peduncles. So it will be a ipsilateral ataxia and the dysmetria. And what does this term means, the dysmetria?
Overshooting of the finger.
Yeah, you will get the overshooting of the fingers, right? And look for the other signs. And what are the other nerves which are supplying my medulla, which are originate from my medulla?
9, 10, 11, 12.
Yeah, 9, 10th, and 11th, 12th. Okay, so the 9th symptom will be present, 10th symptom will be present, 11th symptom will be present, but the 12th will be present in the anterior side, and that's why in the ASI damage we have a damage of 12th nerve, and the little medullary syndrome will be having a damage of 9th, 10th, and 11th, and these are the specific for my medulla. 8th and 5th are not specific; they are present in both my medulla as well as my pons. Okay.
Yeah.
So all of these symptoms are common for both my ICA as well as my PICA. That means for my little pontine as well as my little medullary syndrome, except these cranial signs. Okay.
Yes.
So I have no need to mention all these symptoms. Just know in case of ICA, you will have a damage in the lateral pons, and because of that, the facial nucleus will also die along with all these nuclei. Same symptoms, but you will get the facial paralysis. Okay. Very important. And it would be a lower motor neuron damage because the nerve are originating from here, right? So it would be a lower motor neuron. Complete one side of the face will be paralyzed. You will have a degree lacrimation, degree salivation, taste senses from the tongue will be lost. Rest all the symptoms of Horner syndrome, vertigo, nystagmus, loss of senses from my face, right? Loss of pain, temperature will be same for both of these lesions. Is that okay?
Yeah.
And because of my loss of this facial nerve, you will also get the hyperacusis, okay, in which you have a very increased sensitivity for the sounds. Even a very little sound will irritate you. Okay. Now, any doubt on this page? Please ask.
No, thank you.
This is my lacunar effect. We have discussed that it's applied deep structures like the internal capsule, corona radiator, and other parts. Lipohyalinosis, microtherioma will be formed, and that happens because of the hypertension. Right? These arteries will get die. You will either get a pure sensory stroke or you will get a pure motor stroke. Yeah. Now, when the two vestibular-basilar arteries join, they will form the basilar artery supplying the anterior pons. So, see, the anterior spinal artery supplying the anterior medulla, okay, pica supplying the posterior medulla, right? Basilar artery supplying the anterior pons, and the ica supplying the posterior pons and the lateral pons. Is that okay?
Yes.
Yeah.
Now you have the basilar artery supplying the anterior pons, so you have the damage of the corticospinal, the corticobulbar tract. And please note, bilateral damage occur because of the basilar artery because it supplies bilateral pons. The antispinal artery supplying the unilateral medulla, you will get the unilateral symptom because of that. In case of basilar artery, it will be supplying my bilateral pons. So bilateral paralysis will be there, bilateral loss of senses will be there. Okay. So if the RAS, which is reticular activity system, if it is preserved, you will have a normal consciousness. If that system died, the patient will be going to the coma. You will have the quadriplegia, loss of all the voluntary movement of the facial, mouth, tongue. Okay, they all will be lost. Patient will get the horizontal loss of horizontal eye movement because for the gaze you need the sixth nerve, right? The sixth nerve will die. So as a result, you will have a loss of horizontal gaze. But the vertical gaze, it is given by the superior colliculus, right? So the vertical gaze will be impacted, but you get the loss of horizontal gaze. And this is known as the locked-in syndrome. Is that okay?
Yes.
Complete paralysis of all the body parts. You can sense everything. They can sense the pain. They can sense the temperature, but they just can't do anything. Their body completely paralyzed. Okay. Now, you can also get the locked-in syndrome after the central pontile demyelination. So how can you identify, looking on the MRI, okay, a central pontine demyelination versus a basilar artery stroke? You got a patient who is having a locked-in syndrome. That means he's completely paralyzed, right? And now you want to know whether this paralysis happened because of a stroke or because of the central pontine demyelination. How can you identify on the MRI? Of course, you perform the MRI first.
Vascular changes should be seen in stroke,
What vascular changes?
like any kind of ischemia, like any thrombus or hemorrhage.
You can see a thrombus looking in the MRI, by the MRI.
Like if it is a large thrombus, yes, we can see.
Are you sure you can see a thrombus in the MRI?
Yeah, like for deep venous thrombosis, for the brain, the dural venous thrombosis, those can be seen. I'm not sure about the arterial thrombus.
Of course, vein thrombosis can never happen in case of my brain. Will be a artery thrombus only that can cause my infarction. It is not just a deep vein thrombosis, which it happens in the leg only, right? Not in the brain.
Yeah, I'm talking about the dural vein thrombosis. Those can be seen sometimes in the MRI.
But in case of this lock-in syndrome, we are talking about the artery thrombosis because it is a basilar artery, right? It is not a vein.
Yeah.
So, any other? What you will see, I see swelling in central demyelination. No. We have passed the swelling. Actually, in order to correct the swelling, I got this condition, the central demyelination because of this swelling. In order to correct that swelling, I got that condition. So, no, I won't see it. What you will see on a patient MRI when he got a ischemic stroke, I told you, what you will see on the MRI of the patient? What kind of a lesion I can expect?
Hypodense.
A hypodense lesion. So if you see a hypodense lesion on the MRI, you will know that it is a ischemia. Okay. If you see, the loss of demyelination, that means a gray matter in the white matter, you know that it is because of the demyelination. The grayish plaques you will see. Whenever you see them plaque-like structures, that means it is because of my demyelination. Whenever you see a hypodense region in my CT, what you will see is the stroke. Is that okay? Or a hyperdense lesion even, because if it is a hemorrhagic stroke, right?
Hemorrhage.
Okay.
Yes.
Yeah.
So note that condition, okay? Very important. Okay, now you have the posterior cerebral artery that's supplying your occipital lobe and some part of your middle brain also. So what you will get is the contralateral hemianopia with macular sparing because this macula has dual blood supply. So the macula will be spared. We will talk about that later, don't worry. And you will get the alexia without agraphia. Okay. And the midbrain structures are also get damaged. You will get a damage of third nerve. You will get a damage of fourth nerve. So these deficits are generally also present whenever you get a posterior cerebral artery damage. Okay, very important. So yeah, so as you can see, if I'm seeing this kind of an MRI, this means what kind of a stroke my patient is having. Which artery I am asking?
Mid MC.
Yeah, what?
M.
Yeah, middle cerebral
MC.
artery, right? Now look at the figure B. What stroke I'm having?
M.
Yeah. This is stroke. As you can see on the arrow, this is the part where the patient brain is dying. So what kind of a stroke can do that?
Ischemic stroke.
Yeah, but what arteries is involved?
Lenticular striate.
Exactly, lenticular. See, the
Lenticular
smaller
striate.
portion of my brain is tied. And if the smaller portion of my brain is tied, that means it must be a very small artery, right? And only the lenticulostriate vessels can do that, supplying a particular structure. That means a particular thalamus or a particular, you can say, the internal capsule, right? So this must be a case of my the putamen damage. Okay, where here lies my putamen, right? Now looking at the C, what artery can do that?
Posterior cerebral artery.
Yeah, cerebellar artery. Okay, the pica, because it is a region of my cerebellum. As you can see, the
Okay,
cerebellum
yeah.
has small hemispheres, right? So this must be my cerebellar artery, not the cerebral artery. Okay. Then look at this MRI. What artery can do that? What part, what lobe of the brain is it?
Occipital.
Occipital.
So what artery supplying the occipital lobe?
PCA.
Posterior cerebral.
So what take you so much time? It must be the PCA, right?
Mm-hmm.
Look at the brain part. Okay. And then you can identify what artery can do that, right? So what symptoms my patient can expect when he's having this kind of a stroke?
Visual disturbances.
Visual disturbance.
Yeah, he will have a hemianopia. Okay. Any other thing?
Macular sparing.
Yeah, macular sparing would be there. Good. He cannot identify anything, okay, without touching it. Okay. Even if if someone is present in front of them, okay, the patient cannot identify them. Okay, only by touching them he will know that yeah, this is him. Okay. If you if you bring a phone in front of them and you ask them to identify this, he cannot do that. But if he touch a phone, he will know that yeah, this is a phone. Okay. So
Yes.
visual agnosia can also be there in case of my PCA. Okay. In case of cerebellum, you will get the ataxia. Okay. And because it is a pica, so what you will, what other symptoms you will get? What brain stem will be get damaged? What part of a brain stem? Pica. What part of my brain stem will die because of the pica?
Pons. The posterior part of the pons.
Pons.
Yeah.
Pons or medulla.
Posterior medulla.
Posterior or lateral medulla, you can say, right? If the lenticular vessels can die, so what symptoms you can expect because of this kind of a stroke? What patient can give you?
Movement disorders.
Does my patient have a complete sensory loss or a complete motor loss because of this kind of a stroke? Looking at the patient MRI, what you can tell? Whether the patient is having a complete sensory stroke or a complete motor stroke?
Motor.
Why not sensory?
Sensory will include the thalamus, and thalamus is medial to the pointed
Yeah,
arrow.
exactly. Thalamus will be in the medial, right? So patient won't get the sensory symptoms, but the internal capsule will be affected, and the putamen will also be affected. So patient will get the movement disorders, okay, and he will get the paralysis also, right? Looking at this part, okay, the MCA stroke, the patient will have a loss of this upper limb and the face first, the Wernicke's area can also die because of that, right? So looking at the MRI, they will ask you what symptom patient can be having. So you need to identify the structure first, and then after identifying the structure, you will be able to know that what symptoms patient can be having. They can ask you about the artery name, what artery can do that. They can ask you about the symptom, or they can give you a symptom. They can give you multiple MRIs, and they will ask you what MRI correspond to that symptom, right? So you need to be able to identify the MRI. Are we good?
Yes.
Yes.
Then you have the central post-stroke pain, okay, and you need to know the classical scenario of the patient. It would be a patient with a history of stroke, okay. It could be a old age patient or a patient with any trauma history, okay. And now after some time, patient started having the sensory or the motor losses, okay, along with a constant intense pain and loss of senses. Okay, a patient with a previous history of a stroke, that means a patient will be having a history of either the paralysis or might be a sensory loss. But now after 1 or 2 months later, the patient started having this constant pain, okay. And if the patient is having only the motor loss previously, now he started having the senses loss also, and that because of the involvement of the thalamus. Are you getting my point?
Yes.
So it doesn't matter what the patient history was. If it was a history of a complete sensory loss or might be any part of the limb that become paralyzed because of the stroke previously, now the patient is presenting you to a department with a history of a pain, a constant intense pain will be there. And because the thalamus is involved in this disorder, you will have a complete sensory loss of one part of the body. It could be a patient who is having a sensory loss of a limb before, but now he's having a complete loss of senses of one side of the body along with the pain. And you know that the patient is having a central pontine pain syndrome. Is that okay?
Yeah.
Yeah.
So this is a central pontine pain syndrome. Now you have the diffuse axonal injury, and that happens because of the shearing forces with the rapid acceleration and deceleration. See, annotate. This is your cell body. Okay, these are dendritic ends of the cell body. Okay, now where my cell body present, I call the gray region, right? The gray matter. Okay,
Yeah.
and that gray matter is the cortex of my brain, right?
Yes.
So this part is the cortex of my brain, and where my axons lie, this part is known as the medulla of my brain, right? The white matter.
Yeah.
Okay, now because of a sudden acceleration and deceleration, because this part of the axon is very weak, with sudden acceleration or deceleration, this part will get damaged. What happens is something you will see like that. If this is my cell body, this will happen. Is that okay?
Yeah.
Because of a certain acceleration or deceleration. So this is known as a diffuse axonal injury. Okay. Now, as a result, all the functions which are performed by these neurons, because they will die, as you can see, you will have lesions at the junction of the gray matter and the white matter. Okay, the patient will have a multiple lesions at the junctions of the white matter and the gray matter. Very important. Okay, initially at the time, the CT is absolutely normal, and that's why CT is not a test of diagnosis. MRI only can show these changes, so you need to perform the MRI on the patient. Okay, very important. The patient often ultimately go into the coma because of that. Is that okay?
Yes.
Yes.
Yeah, here it is. Sure. Now, because of a direct brain trauma or sudden acceleration or deceleration, you will be having a shearing of the white matter and the gray matter, right? Now, the secondary biochemical changes will be there. The degeneration of the axons will be there. You will have the accumulation of the axonally transported materials. Okay, and in the axons, you can find the amyloid precursor proteins, alpha synuclein. Now, these are not the pathological proteins. Please note, although they can cause the pathology of certain diseases, these are not the pathologic proteins. Okay, they are required for the normal functioning of my axons. Okay, so
Yes.
normally your axons contain these proteins for the normal functioning. So when the axons die, as you can see, all these cell bodies will be releasing all these proteins within, outside in the outside environment, right? So you will be having an accumulation of the axonally transported proteins. Axonal swelling would be there at the point of injury, which means, the axonal bulb formation will be there at the junction of my cell body and my axon. I will have the axonal bulb formation. On the CT, because I cannot show anything, you will have to do the MRI. It will show the lesions at the gray white matter junction. On the microscopy, you will see the axonal swelling. Okay, and this swelling is most pronounced at the gray white matter junction. Is that okay?
Yeah. Yeah.
And that was the figure I was talking before when we discussed about the diffuse brain injury. Yeah. Okay, these kind of strip-like lesions you will see. Okay, and the wedge shape infarcts would be there. And all of these lesions are few centimeter lateral to my midline, as you can see. Okay, so these are the watershed areas, and that's how the Staven will give you this representation of the patient, right? They won't give you the figure, they won't give you the MRI. They will explain you the MRI of the patient, that it will be a wedge chip infarct in the form of some strips which are parallel to each other, few centimeters apart, right? You will have to know that these are the watershed areas, and the patient must be having a hypoxic injury. A diffuse brain damage will be there, a global ischemia, right? This will happen because of the global cerebral ischemia that we have discussed, because of any shock. Okay,
Yeah. Yeah.
so that was it. Any doubts so far, please ask.
No, thank you.
No, thank you.
Okay, I think we should take a short break and then we discuss the fascias. Okay.
Yes.
Okay. Yeah.
Okay.
Thank you.
start this. Okay, so let's start the aphasia. Okay, so first of all, you need to identify the difference between the aphasia and the dysarthria. Dysarthria occur because of the paralysis of your face. You cannot speak. So you have the slurring of the speech, they call it. Okay, it is because of a paralysis of the muscles which are required for the movement of your face, right? To say something. Okay. And then you have the aphasia, when the damage of the Broca's area or the Wernicke's area or the arcuate fasciculus occur. Okay, you have a normal functioning of the muscles, but the areas which you need in order to move that muscles, they will die, and that causes the aphasia, right? So please note difference between dysarthria and the aphasia, that these two are the different thing. Whenever you have the hyperammonia, you will have the slurring of the speech, right? It is not the aphasia but the dysarthria because of hyperammonia. Okay, so you have four type of aphasias. One is the this Broca's aphasia. Second is the Wernicke's aphasia. Third is the conduction. Fourth is the global. These are the four major type of aphasias you have. Others, you have the transcortical, motor, transcortical sensory, and transcortical mixed. So first, let's talk about the Broca's area. Okay, in which you have a very good comprehension. You can understand every command. You know what to say, but you just cannot say it. Okay, the patient try to say that, but he just cannot say it. So the patient become very much frustrated because they have an insight what's happening to them. They know that they have something problem with them. Okay, so the patient will be good in the comprehension, they follow every command, right? But they have a very poor repetition, they cannot repeat uh, what you ask them to say, right? Very important. And that happens with the right hemiparesis, because a Broca's area is in a very close association with your primary motor cortex, right? So whenever the damage to the Broca's area happen because of the MCA, that can also lead to a damage of your, the upper limb also, right? So this area will be present with the upper limb paralysis also. The patient will have a difficulty in finding the words. The speech will become very short and it contain a lot of pauses. Like if you ask them, to introduce themselves, like a normal person said that I am this person, they will give you I, this person. So they have a lot of pauses and they have lots of missing word in their sentence. Okay. So this kind of a thing will be seen in the Broca's or the expressive aphasia. They want to say it, but they cannot say it. And they are very much frustrated. Then you have the Wernicke's area, okay, in which the patient do not have any insight of their condition. The Wernicke's areas is dead, and that's why they cannot comprehend anything. If you ask them to follow a command, they cannot follow that command because they cannot comprehend what you said to them. Okay, very important. Because the Wernicke's areas is present in the temporal lobe, right? It generally present you with the right superior quadrantopia that we have discussed already. Okay, patients say the sentence, but the sentence is like it is totally meaningless. Okay, their speech is very fluent, they're very much fast, but their speech lack any meaning. They have this word salad, okay, and their speech makes no sense. Okay, and these patients are unaware of their situations, right? Then you have the conduction aphasia, which is because of a damage in the arcuate fasciculus. You have a good comprehension, your Wernicke's area is normal, you can say everything because your Broca's area is normal. It's just the connection between the Broca's area and the Wernicke's area is not damaged. As a result, the patient will say something, they will tell you, okay, but in between, at some points, okay, they just forget what they want to say. They forget the words, they have a lot of mistakes in their speech. Okay, so that kind of a thing is found in the conduction aphasia. Okay, if you want if you ask them to repeat your words, to repeat what you said, they will tell you, but with a lot of mistakes in them. And with the mistake, the patient will also correct that mistake. Okay, they will make some grammatical errors in their speech and they will correct it. They will go back, they will correct it. Sometimes they sometimes even forget what they want to say. In between, in the speeches, they have a very milder pauses and they just stop sometimes, right? So basically, they have the speech which is very much fluent, but with a lot of mistakes. Their speech makes sense, but with the mistakes. And this is the conduction aphasia. Then you have the global aphasia, both the Wernicke's as well as the Broca's area got damaged. You cannot express, you cannot comprehend. Both features are present. Then you have the transcortical this motor, sensory, and mixed, in which the areas around the frontal lobe, around the Wernicke's or the Broca's area, okay, they are damaged. The patient will have lot of pauses, they have lot of grammatical errors, okay, they have everything, but their repetition is good, and that is the important thing. They have a features like the Broca, okay, but the repetition is good. In transcortical sensory, they have a features like the Wernicke's, but the repetition is good again. In the mixed type, they have a both features of Broca's as well as Wernicke's, but if you ask them to repeat some sentence, they have a very good repetition. Okay, so any doubt on the aphasia?
No, thank you.
Now, the step one, they do not give you the Broca's area or the Wernicke's area in the option, but they change their name and they give you either the sensory aphasia or the receptive aphasia, okay, for the Wernicke's, expressive or the motor aphasia for the Broca's aphasia. Okay, so know these names also, very important. Then let's discuss the aneurysms. You have two types of aneurysms in the brain, just like other part of the body. You have the sacral aneurysm and the Charcot-Marie aneurysms. Okay, the most common location of the sacral aneurysm is the junction of the anterior communicating artery and the anterior cerebral artery. Okay, and as a result, initially patient they generally do not have any symptom until very late in the disease when these aneurysms got ruptured, and when the aneurysms got ruptured, the patient will get what condition?
Hemorrhage.
Subarachnoid hemorrhage.
Hemorrhage.
Okay, because of the sacral aneurysm rupture. Now, once the aneurysm was expanding, it can it can compress the nearby structures. Okay, and the symptoms because of the compression of these nearby structures can happen. The patient can get a focal neurologic deficits because of the expansion of this type of this aneurysm, right? If the aneurysm is present in the anterior communicating artery because it is in the central location, patient can get the contralateral lower extremities hemiparesis. Patient can get the sensory deficits in the lower part, the lower limbs. Patient can get the incontinence also. If the aneurysm is present in the middle cerebral artery, patient can get the contralateral upper extremity and the lower facial hemiparesis. Okay, and the sensory losses also. If in the posterior communicating artery, patient can get the ipsilateral cranial 3 palsy also. So depending upon the location of the aneurysm, patient can get symptoms because of that. Okay, and the risk factors of these aneurysms are very important. Okay, they will ask you the risk factors specifically. So you need to know that the autosomal dominant polycystic kidney disease, Ehlers-Danlos syndrome, okay, correctation of the aorta, Turner syndrome, bicuspid aortic valve, okay, Turner syndrome, bicuspid aortic valve, correctation of aorta, Ehlers-Danlos syndrome, autosomal dominant polycystic kidney disease. These are the most important risk factors for the sacral aneurysms. Okay. Now you have the Charcot-Marie aneurysms, and that happens in the patient with the history of chronic hypertension. Okay, and that can lead to a rupture of the lenticulostriate vessels. So you get the either complete sensory loss or a complete motor loss of one side of the body. Okay. So because of a rupture in the sacral aneurysm, you will have the blood accumulation in between the sulci, as you can see, right? And that you can see on the MRI of the patient also, the blood in the sulci. In case of Charcot-Marie aneurysms, if they get ruptured, you will get an area of hyperdense region in the brain, in the CT, right? Any doubt on the aneurysms?
No, thank you.
Okay. Now you have the seizures. Okay, so just give me a second. Okay, welcome again. So does anyone here has a perfect knowledge of seizures? I have 5 participants right now. Oh, 3 only, because 2 are me. So out of 3, does any of you have any perfect knowledge of the seizures? Or you have
Not
lots
me.
of confusion? Or you have lots of confusion in the seizures?
Yeah, there's a lot of confusion in this topic.
Yeah.
What about the rest? Yeah. After
Yeah.
that, it won't be like that, okay? Okay, so see, I've gave you a basic idea of the seizures before, that it happens whenever a certain area in your brain become hyperactive. Okay, and whenever the hyperactivity in that brain, in that part of the brain happen, it will send the impulses, and that will cause the symptoms. For example, if it is a primary motor cortex where the this hyperactivity occur, you will get the shaking of the hands or the shaking of the legs or a complete one side of the body, right?
Yeah.
Okay, so seizures are nothing but just a hyperactivity of one part of your brain or a complete brain sometimes. Okay, because these nerve impulses are nothing but just the flow of the ions. This action potential is nothing but the flow of ions, right?
Yes.
So any kind of tissue infiltration, any kind of tumor, any kind of a trauma can interfere with these ions, and that can cause a hyperactivity or a hyperflow of these ions, and that can cause a seizures, right?
Yeah.
Yes.
You have 2 type of seizures. One is the focal seizures and second is the generalized seizures. Focal seizures happens whenever a certain part of your brain, for example, the Broca's area or the Wernicke's area or the primary motor, primary somatosensory cortex, will be a particular part of the somatosensory cortex. It will become hyperactivated. It start these rapid neuronal firings, and that causes symptoms. If it is a visual cortex, the first symptom will be the aura, any kind of a flash or any kind of a visual you will see. If it is a olfactory cortex, you will see some smell, some kind of. If it is a somatosensory cortex, it will be some paresthesias or abnormal senses. If it is a motor cortex, you will see the shaking of your body part, right? So depending upon the site of origination, patient can have a symptoms first of that part. Okay, now you should also know that these partial seizures, they will first causes the diffuse involvement of one side of the brain. Like if the somatosensory cortex was there, one part of the somatosensory cortex, it will involve the complete somatosensory cortex, then the complete the sensory cortex, and the motor cortex also, and then the other parts of this unilateral brain, and then the bilateral brain will be involved. So maximally, the partial focal seizures, they become the generalized seizures. You getting my point?
Yes.
Yes.
For example, if I draw my figure, if this is my patient, yeah, let us suppose they have some disturbance in the primary motor cortex, and that part, which is supplying my hand, okay, that become a very hyperactive part. So what does it cause? It will cause us seizures or some hyperactivity in my upper limb. It will cause a shaking of my upper limb first. So the patient will present you with a history of tremors or some kind of a shaking first. Now soon, this part involves the nearby structures. That means my complete this motor cortex, and as a result, I will have the complete shaking of one side of my body. Okay, and soon the somatosensory cortex, the Broca's area, the visual cortex, complete structure, complete one side of my brain will be involved in that. They will all started firing these hyperactive these impulses. I will have all kind of a symptoms in that, right? Very importantly, and then soon the other half of my brain will also be involved, and I will get the bilateral seizures, a diffuse type of seizures. Okay, so symptoms originated in one part of my body. It will involve complete one side of my body, and then the both sides will be involved, right?
Right.
Yes.
So this is my focal seizures, a partial focal seizures. Okay. You have two types in it. One is the simple partial seizures, and second is the complex partial seizure. In the simple partial seizure, you have a normal consciousness. Patient will tell you that they have the history of this handshaking or abnormal senses was there. They will tell you that. In case of a complex partial seizures, they do not have any consciousness. They do not know what happened to them. So they won't give you any symptoms, any history, but the person who was watching that person, that patient, they will tell you that the patient was initially having this shaking of one hand, then the complete body part, and then the complete body. Okay.
Okay.
Now
Okay.
sometimes what happened, if let us suppose the part the brain which sometimes let us suppose it is not, if it is not the motor cortex but any other part of your brain is involved in the seizure, let's say the visual cortex, okay, and you got the complex partial seizure. In that case, you won't get any contraction of the body part, right? You won't get any shaking, but what you get is the blank stare. The patient will just sit down and blankly stare the wall without doing anything, right? And
Yeah,
that's
yeah.
how you know patient is having a complex partial seizure. Now the similar thing can also happen in the absence seizure. Patient will have a history of a blank stare in both the cases. So how will you tell whether the patient is having a complex partial seizure or absence seizure? Confusion, right?
Yeah. But in complex partial
Absence.
seizure, later on
Con.
there will be motor involvement.
There will be these are the chances, not the every time.
Okay, okay, yeah.
Chances are there, but not the every time. Okay. If the
Okay.
seizures are limited, they will limit it to that particular brain part only. They won't spread to other regions. But it happens most of the time, but not every time, right? Because these seizures are nothing but just the flow of ions. The flow of ions will disturb the other neurons also, other body parts, other brain parts also. You will get the bilateral seizures sometimes, but not every time. Okay.
Yeah.
So now it become very confusing to determine the difference between the absent seizure and the complex partial seizure. We will come to that in a second. Don't worry. I will make it easy for you. But just know that you have two types of seizures in the partial focal seizure. One is the simple and second is the complex. Okay. Now, you call it a epilepsy whenever you have a repeated episodes of seizures. Okay. Yeah. So these are known as epilepsy. Whenever you have a repeated episodes of the seizures, okay, you will call it a epilepsy. You will call it a status epilepticus whenever you have a continuous seizures, okay, with a gap in between 5 minutes. You have one episode of seizure, then within 5 minutes, before the patient gains his consciousness, he has another episode of seizure. This hyper contraction or sudden this blank stare or anything could be, right? Within a difference of 5 minutes, the patient have a repeated episodes. You call it the status epilepticus. Is that okay?
Yes.
Yes.
Now comes to the generalized seizure, in which both part of your brain, both hemispheres are involved at the same time. It's not just a body part, so you won't get any focal contraction, any part. It will be a diffuse type thing. You have this absence seizure, okay, and that happens whenever the patient has a history of blank stare, just sit blankly, staring at the wall, doing nothing. Okay, so this is known as the absence seizures. You have the myoclonic seizure, in which you have a quick repetitive jerks. Okay, and the frequency of these jerks will be increased with the lack of sleeping. Generally the patient will have these myoclonic seizure just before the sleeping or just after the sleeping, after they woke up. Okay, you call it a myoclonic seizure. And with the sleep deprivation, okay, these kind of seizures will be provoked with the sleep deprivation. Okay, very important. Then you have the tonic clonic seizure. Okay, in this case, first you have a tonic phase, then you have a clonic phase. In the tonic phase, your muscles will become very much stiff. Okay, and then you have the clonic phase, in which you have the repetitive jerks. As you can see, first you have the tonic phase, in which your muscles become very much stiff, and then you have the clonic phase. You have a flexion of both the upper limb and the lower limb in that. Okay, then you have
Yeah.
the atonic seizures, in which the patient was just walking and then he suddenly dropped. Okay, you call it a atonic seizures. Sometimes even the physicians can confuse it with the episode of a syncope. Okay, atonic seizures can be confused with the episode of syncope sometimes. Okay, so you need to be very much careful. You need to perform the CT, MRI of the patient whenever you heard that condition. Okay, then you have the atonic type of seizures. Sorry, it was not the tonic, but it was this type of seizures which can be confused with the fainting or the syncope, right? The atonic seizures. In the tonic seizures, you just have the tonic phase, which is the very much stiffening of all the these body parts, right? So these are different kind of seizures you can get. Okay. Now let's discuss how you can differentiate between the. I'm sure you have seen this table in the U world also. You have the simple partial seizures and the impaired awareness or the complex partial seizures. In the in the simple partial seizures, you are having a seizure in one part of the body. It will spread to a complete half of the body and then to the bilateral. Okay. A specified muscle group will be involved first and then the complete part. In the impaired seizure, you will be having a blank stares. And after the episode of seizure is over, after the episode of seizure, what you will get is the post-ictal, that means a post-seizure state, which is full of confusions. Patient will have a confusion, drowsiness, okay, he will, after the seizures. They do not know what happened to them. You know, it will take time like 15 minutes or even an hour for them to regain their consciousness, to know where they are, what they are doing, right? So they get the episode of seizure and they just forget everything after the seizure, right? They don't know what's happening to them. Okay. During the episode of seizure, patient can also have something known as automatism. The part of the brain which was involved initially, okay, because it will be sending impulses at the time of seizure, patient can saw some visual effects. Okay, patient can be doing the cycling. So you know, look for any hand movement of the patient, like they will be doing cycling. So they will be when you look at the patient, it will seem like they're doing cycling, but they don't have a cycle, of course. It will be the muscle movement like in the cycling fashion, like they're saying something. They have this lip smacking or lip movement like they're talking to someone, right? So anything apart from the seizure which you see in the patient at the time of seizures, you call it a automatism. It could be anything. It could be a salivation, it could be a tearing, it could be a cyclic movements, like it could be anything. Okay, so automatism will be present in the impaired seizures, and it must be start unilaterally, and sometimes it can spread bilaterally also. Is that okay?
Yeah.
Yes.
We will come to that again, don't worry. In the previous page, I've noted all the difference between them. So we will come to these points again, just know for now. Then you have the generalized seizures that involves both the hemispheres, okay? And you have the tonic-clonic seizures in which the patient loses their consciousness. They have the post-ictal state. They have a contraction, stiffening of the muscles, okay? And they have a post-ictal confusion. Sometimes they bite their tongue. They even micturate at the time of these seizures. So look for the urination, look for the tongue biting, okay, along with the jerks and the stiffening. That means it is a tonic-clonic seizure. You have the myoclonic, in which you have a brief jerky movement, like a sudden jerks, okay, in the hand, and sudden jerks, and that happens just before you go to sleep or just after you wake up. With the sleep deprivation, you will get a more jerky movements. Absence seizures, okay, you will have a blank stare, and please note, in absence seizure, you do not have any post-ictal confusion, and that is the main thing that will help you determine. If the patient got confused after the episode of seizure, and it take you, it take the patient along, around 15 to 20 minutes to regain their consciousness, that means it is a partial complex seizure. If the seizure episode is over and they suddenly regain their consciousness, okay, that means it was a absence seizure. Generally, in case of absence seizure, patients do not have any automatism, or they have a very minimum automatism, like lip smacking only. No cyclic movement, no eye movement, no tearing, no salivation, nothing. No speaking to anyone. It's just a lip smacking sometimes present. Okay? Is that clear up to here?
Yeah. Could you please repeat what cannot occur in absence seizures?
We will tell you, don't worry about that. Is it clear up to here?
Okay.
We will come to that
Yes.
again, don't worry.
Yeah.
Okay, now let's go back and note the difference between the absence seizures and the focal impaired seizure. Now, the presentation of a patient for the focal impaired seizure. Okay, please note that the episode will be maximum 2 episodes per day. Okay, and these episodes last for several minutes. The patient will have a history of blank stare for like 2 to 5 minutes. They will just sit down on the chair, staring blankly at the wall, doing nothing for like 4 5 minutes. You know that the patient is having a focal impaired seizure. Okay, it can happen anytime in any situation, like while walking, okay, while during exercises. Now, if the patient, so you see, there's no focal contraction of the muscles, there's nothing, it's just a blank stare. Okay, it's doing nothing to the patient. And why these seizures are harmful to the patient?
Because the patient is
As
losing consciousness at that time, and
brain,
Exactly,
brain
like
can
while
be
hemorrhage.
an
crossing
accident.
exactly, like while crossing the road, if they get this episode, they will got an accident, right? That's why these seizures are very much harmful. While during the exercise, if they got this episode, they will get injured at that time, right? So that's why these episodes are very much harmful for the patient. These episodes begin abruptly, okay, and the patient cannot be interrupted. You try to woke up the patient, like, listen to me, what happened, but they just do not respond to you. They have this episode which will last for up to 5 minutes. Minutes are there, not seconds, but minute is the very important thing. With the steering, patient will also have the automatism. It might be a clenching of the hand, either a grunting sound, it could be a crying, it could be a lip smacking, it could be a tasting something, it could be a grabbing something, it could be like walking, okay, it could be like on a cycle, like a cyclic movement, okay, it could be anything along with the seizure episode. Look for that in the patient. They will tell that the patient was appearing like he's eating something, or like uh, he's doing cycling, or like he's walking on a garden, or like he's talking to someone. Okay, the patient will give you this type of history. Okay, the one who observed the patient, they will give you this kind of a history, right? And after the episode, the patient will get confused, and it took them around 15 minutes to regain their consciousness. In that time, you cannot do anything again with the patient. So the total episode of the focal impaired seizure, it lasts for 20 minutes around. Once they get the episode, it will take them around 20 minutes to get back to normal. Is that okay?
Yes.
Yes.
Any doubt in part?
No, thank you.
No, thank you.
Now you have the absence seizures, which are basically the diffuse kind of seizures, right? That happens many times per day, because these episodes are last for like 20 seconds only. Okay, so blank stare for seconds only, it would be the absence seizures that happen multiple times. It can again occur in any situation, again occur abruptly, patient cannot be interrupted. Okay, usually patient just stares without doing anything, but sometimes minor movements can be seen, just like your automatism, but these movements are generally limited to the lip smacking or eyelid twitching only. No other complex movements like tasting, crying, talking, walking, cycling. These movements won't see, right? It just minor movement like the lip smacking or the eyelids twitching will be seen. Patient will become very much alert soon as the episode over. So a total time when the patient get an absence seizure, it will be only 20 seconds. While in case of a partial complex seizure, it would be around 20 minutes. So these are the difference between the two type of seizures. Okay.
Yeah,
Any
cool.
doubt now?
No, thank you.
No, thank you.
What are the automatism? These are just the involuntary movement that are happening with the patient at the time of epilepsy. As if you're doing some kind of activity like bicycling, like rubbing hands, like clapping, lip smacking, grunting sound, anything could be there. Sniffling. Okay, anything along with the epilepsy, it will call the automatism, right? Automatism is seen with the partial seizures, not with the these the generalized seizures. Okay.
Yes.
Yeah.
Once you diagnose the patient, once you know that the patient is having either the partial simple seizures, in the simple seizure, they have the insight completely. Okay, they have the consciousness completely. They will tell you they had this shaking of the arm and then they got a bilateral shaking of the body. They will tell you this. And if they are telling you that the seizure began with a focal contraction and now the bilateral, that means it is a simple partial seizure that becomes generalized. If they give you a history, of a patient, if patient give you a history of this sudden jerks that happen before the sleep or after sleep or provoked with the sleep deprivation, that means it is a myoclonic seizure. If they give you, the patient won't give you, but uh, uh, if the surrounding people give you some kind of a history, the patient first have this very much stiffening episode, and then the focal contraction, and then the bilateral contractions begin along with the urination or the tongue biting. That means it is a tonic clonic seizure. If the patient just got an episode of syncope, that means it could be a atonic seizure. Okay, and yeah, if they won't give you any, if the patient won't give you any history, but the surrounding people give you a history of blank stare, then you need to identify the duration of this blank stare. If it is minutes, that means it is a partial seizure, absence partial seizure, the complex partial seizure. If the history is in seconds, that means it is a simple this absence seizures, right? Look for the automatism, look for the post-ictal confusions. These will help you determine the cause of the seizure. Now tell me any doubt.
No, it's clear now.
No,
Thank you.
clear. Thank you.
I hope you will now able to identify the type of seizures. Okay.
Yes.
Yeah.
These are nothing but just a high frequency firing of the neurons, right? It is because of a high ion flow. So this high ion flow can disrupt other neurons also. So that's why these waves are generally spread to a complete half of your brain and then to the bilateral brain. And these, whenever you got a patient with the seizure, you always need to do the MRI to make sure the patient is not having any kind of a brain lesion, because any kind of a brain lesion can do that. The hemorrhagic stroke or ischemic stroke or any kind of tumor, any kind of a tissue infiltration, like in case of hemochromatosis, you can have it, right? Any fever can even do that. Okay, any abnormality in the ion conduction can do that. Okay.
Yeah.
Yeah.
Depending upon the cause of the seizure, now you have to treat it. Okay, for the focal seizures, okay, the most common drug will be your the lamotrigine. Okay, you can also use the carbamazepine for the focal seizures. Very important. It is a first line therapy for the focal seizures, but the most commonly used drug is the lamotrigine. Okay, and the valproic acid also. Lamotrigine and the valproic acid are the most commonly used drugs for the focal seizures. If you got a tonic-clonic seizure, you can use the phenytoin. The seizures will become bilateral after the partial. Okay, first we have the partial episode, the focal episode, and then the seizures become bilateral. For those type of seizures, you can use the carbamazepine. Okay, but if the seizure was a generalized type of seizures at a very initial, okay, that means you cannot use the carbamazepine in those patients. Okay, you use the phenytoin, valproate acid, levetiracetam, and the carbamazepine only for those partial seizures will become bilateral. For the myoclonic, you can use the valproic acid, levetiracetam. For the absence seizures, you need to use the ethosuximide and the valproic acid. Okay, you cannot give this ethosuximide or a valproic acid to that patient who is having a blank stare for minutes. We will give only to that patient who is having blank stare for seconds, right?
Yeah. Yeah.
Yeah.
So that's all about the seizures. Okay, now the causes of the seizures in the children, it could be genetic. Okay, so the multiple family members of the patient will have a history of the seizures. It could be infection, and you call it the febrile fever, and you only call it a febrile fever whenever you exclude all the causes. Like the cause of meningitis must be excluded, any tumor, any trauma must be excluded. Okay, whenever you exclude every cause of the seizure, the only thing you are left with is the infection, is the febrile seizure. And please note, the infection must not include in the brain. It must be in the other part of your body, and you're having fever, and because of the fever, you're having the seizures. Because in case of meningitis, you can have the seizures again, and you won't call them the febrile fevers, right? It could be a trauma, it could be congenital, it could be metabolic. Because whenever you got the hypoglycemia, like in case of all this sugar metabolism disorders, okay, and in case of the myocardial disease, right? Whenever you have the hyperglycemia, you can have the seizures also. In adults, it could be a tumor, it could be a trauma, it could be a stroke, it could be an infection, and that's why you always need to perform the MRI of the patient. In the elderly, it could be a stroke, trauma, tumor, metabolic, and infections. And depending upon the cause, now you need to treat the patient. Okay. Okay, any doubts so far?
No, thank you.
No, thank you.
Okay. Now you need to know the difference between the fever and the heat stroke. Fever happens whenever the prostaglandins stimulate your hypothalamus to raise the temperature of your body, to raise the set point, right? And heat stroke happens whenever the external heat enters in your body. Okay, it is not physiologically induced. It is just external heat. Whenever you cannot dissipate the heat of your body, you will get the heat stroke. And the body temperature was generally more than 40 degrees centigrade Celsius. Okay. In case of a fever, the temperature usually less than 40 degrees Celsius. That means less than 104 degree Fahrenheit, I guess. Okay. So fevers is because of the cytokines like interleukin 1, 6, TNF alpha that will stimulate the prostaglandins, that will stimulate the hypothalamus. And what prostaglandin can cause a fever?
PGE1.
E1 or E2?
I don't remember. I
It
can't
was
recall.
E2, right? It was E2.
Okay.
I think. Let me confirm it. I'm also forgetting because. Yeah, it was E2. Okay.
Okay, yeah, thank you.
Okay, so prostaglandin E2 will cause the fever. Because of the fever, you can get the febrile seizures. Okay, and these are generally self-limiting. Okay, my cousins had these type of seizures when they were very young, less than 4 years, I can guess, right? So management, again, you will have to give the patient acetaminophen or the ibuprofen to control the fever again, because these are the things which are causing these things. Okay, so nothing important. Heat stroke, on the other hand, it is happens whenever your body cannot dissipate the heat, like during the exercise. Okay, in the exercise you got too much of the heat, you need to you need to dissipate this heat from the body. You can do that by the vasodilation, by the sweating, right? But whenever these any kind of these mechanisms got disrupted, what you will get is the accumulation of heat in your body, and that causes a heat stroke. For example, if you take the atropine, for example, the atropine will cause the heat stroke, right? It will cause this hyperthermia, you call it, right?
Yeah.
That happens because you have the loss of sweating, you have the loss of vasodilation, and that causes the accumulation of heat, and that can cause the heat stroke, right? Similarly, other drugs can also cause the heat stroke. For example, the aspirin therapy. If you give too much of the aspirin, patient can get the hyperthermia, can get the heat stroke, right?
Yeah.
So the complications are very important. Now, before we go that, we need to discuss all the causes of the heat stroke. Okay, what scenarios could be with the patient that will prevent them from losing their heat. Okay, just give me a second. Yeah, like I told you, whenever you got the hyperthermia, whenever you got a high heat, your body does what? It will cause a vasodilation, it will cause a sweating, it will decrease the thyroid hormone, right? So ultimately increasing the loss of heat and decreasing the metabolic demand, right?
Yeah.
So in order to do that, okay, just give me a second. Yeah, in order to do that, you need to increase the sweating, you need to increase the cardiac output, You need to cause the peripheral vasodilation. You need to cause the splanchnic vasoconstriction. You need to increase the parasympathetic system, and you need to decrease the thyroid production. These 5 points, you can note that in your first aid. Very important. Sweating, increase in cardiac output, vasoconstriction, peripheral vasodilation, thyroid production will be decreased, and the parasympathetic system must be activated. Only then you can get a loss of heat, right?
Okay.
What's the link between parasympathetic system activation and heat
Because
loss?
the parasympathetic system, whenever they get activated, they will cause a peripheral vasodilation, right? Because it means the sympathetic system must be inhibiting, and the sweating will be happening because of that, right?
Okay, yeah.
Okay. Now, in elderly patients, okay, they have the decreased surface area of the skin. Okay. And because of that, they cannot lose their heat properly. Okay. Getting my point?
Yeah.
They have a loss of, remember the ratty ridges we have discussed? These kind of finger-like projections were there in your skin, right?
Yes.
You have the stem cells there, right? These ratty ridges will be lost in the elderly. And as a result, the surface area for the transfer of heat, it will be decreased. And that is the one cause why the elderly patient got the heat stroke. Second is, in their skin, they have a decrease in the sweat gland density. And because of a decrease in sweat gland density, you have a loss of sweating. And because of that, the old age patients can get the heat stroke. Third is the peripheral contraction of the vasculature, the tonic contraction of the vasculature periphery. And because of that, you will have a decreased blood flow in the skin, in the elderly I'm talking about. And that's why they get a heat stroke. So 3 important causes for the heat stroke in elderly. One is a tonic contraction of the peripheral vasculature, and as a result, the limited blood will be transferred to the periphery. Sweat gland density will be decreased, and third will be the loss of surface area of the skin. Okay.
Yeah.
Now, other causes are the medical conditions. Like if a patient has a history of chronic heart failure, they have a loss of cardiac output, right? And you need the cardiac output to cause the movement of blood towards the skin, right?
Yeah.
Yes.
So the patients with the chronic heart failure, they are at an increased risk of developing the heat stroke. Third are the patients with the medications. Okay, like if the patient is on the beta blocker therapy, they will reduce the cardiac output, and as a result, the blood flow will be decreased. If the patient has is been on therapy of the anticholinergics like the atropine we have discussed, you will get a loss of sweating, and that can cause the heat stroke, right? If the patient is on a diuretic therapy, they will have a loss of blood volume, and because of a loss of blood volume, they can have a decreased blood flow, and as a result, they will get the stroke. Sympathomimetics, because they causes the peripheral vasoconstriction, they can cause the decrease in heat transfer. Okay, antipsychotic therapies, because it decreases the dopamine, they can cause a vasoconstriction also. And because they're acting on the hypothalamus again, right, they will disrupt the hypothalamic thermoregulation mechanism. And because of this dysregulation in the hypothalamic thermoregulation mechanism, you can get the heat stroke. Okay.
Yeah. Okay.
The old age patients, patient with the morbidities, and patient with the drug therapy, they are at an increased risk of these heat stroke. Please remember that they will step one will give you a patient who is having either of the condition, either of the drug therapy, and they will ask you, why does this patient had this heat stroke? Okay, looking at the drug they are using, you need to identify the cause. Okay.
Yeah. Could you please explain why beta blockers are causing heat stroke?
Because that decreases the heart rate, right?
Okay. All right.
And you know the cardiac output is will be equals to heart rate times the stroke volume. Heart rate is
Yeah.
lost, so cardiac output will be lost.
Okay. Yeah. Thank you.
Now, the symptoms of the hyperthermia, the patient will get the altered mental status. They will become very much confused. The patient will also have the end organ damage, like a high creatine count level, high LFT count. They will have a very high heart rate, low blood pressure. Very important. Flushing will be there. Okay, because whenever you got a heat in your body, the vasodilation will occur. And whenever the vasodilation occurs, the peripheral blood flow will be increased. You will get a flushing. Okay. So the tachypnea can also be there. Okay, trachypnea, high heart rate, low BP, altered mental status. These are the symptoms of the heat stroke. Because of the heat stroke, you can also have the rhabdomyolysis. That means damage of your muscles. You will have a muscle pain. You will have the myoglobinuria. Because of the myoglobinuria, you can have a kidney damage. Acute kidney injury can occur because of the heat stroke, which is the acute tubular necrosis, right?
Yes.
Yeah.
Okay. And the DIC can also happen because of the heat stroke. Very important. So these are the complications, the DIC, rhabdomyolysis, ARDS can happen because of the heat stroke. Okay, so that's why this heat stroke is very much important. Okay, so that would be everything on this page. Now, any doubt?
How DIC?
There is no specific cause. I really don't know, but yeah, it happens
Okay.
because of this procoagulant protein release. Ischemia and necrosis happen,
Yeah.
and all
Yeah.
these things. No
Okay.
specific cause exactly,
Okay.
but it's just a cause, right? So, any doubt on this page?
No, thank you.
I think we should stop here for now.
Okay.
Okay, yeah.
If you want to study, we can continue for another 10 to 20 minutes.
We can continue tomorrow.
Okay.
Yeah, we can continue tomorrow.
Please revise the seizures. These are very important because you need to identify the seizures on the patient presentation. NBME has a very weird and this kind of representations for the patient on the seizures, right? So beware of the seizures.
Okay.
Okay, yeah. Thank you.
Sure. Thank you.
Thank you so much.
Thank you so much.
Thank you so much.